Now we are going to discuss hernia and abdominal wall. What is the definition of hernia? It's the protrusion of viscus or part of viscus through the wall of its containing cavity. Two factors which leads to herniation of abdominal contents. First, if there is weakness of abdominal muscles, and the second, if there is increased intra-abdominal pressure. So any factor which can lead to weakness of abdominal muscles or anything in which there is increased intra-abdominal pressure, both of these are risk factors for hernia. So see the list of risk factors. Patent processus vaginalis in females, patent canal of Knapp, connective tissue disorders like Ehlers-Danlos syndrome, Prune-Bailey syndrome, all these are associated with weakness of abdominal muscles. In Prune-Bailey syndrome, there is weakness of abdominal muscles. Apart from this, ectopia vesicae, if we give lower abdominal incision or there is defective collagen synthesis, if patient is a smoker or there is steroid intake, in all these cases there is weakness of abdominal muscles. Now see what are the factors which are going to increase the intra-abdominal pressure. The patients who are having chronic cough, COPD or bronchitis, they have increased risk of hernia. Why? Because there is too much of effort during coughing and there is increased intra-abdominal pressure. Similarly, if the patient is having chronic constipation or patient is having obstructive uropathy, like in elderly, you can see patients of BPH, benign prostatic hyperplasia, and in young patients also, there can be stricture urethra, right? So BPH as well as stricture urethra, these can lead to increased intra-abdominal pressure because patient has to strain for micturition. Similarly, heavy weight lifting increases intra-abdominal pressure. If there is anything extra or in excess in abdominal cavity, it can increase the intra-abdominal pressure. Like if there is excessive fluid, ascites, if there is presence of mucinous content or jelly known as pseudomyxoma peritonei, or if there is fetus, means pregnancy, all these are going to increase the risk of hernia because these are going to increase the intra-abdominal pressure. CAPD, what is CAPD? Chronic ambulatory peritoneal dialysis. So here also we infuse the fluid in the peritoneal cavity. It increases intra-abdominal pressure and increasing the risk of hernia. So this is the complete list of risk factor which can lead to hernia. Now coming to the question that what's the most common type of hernia in males and females? Most common type of hernia in both males as well as females is the indirect inguinal hernia, IIH. Indirect inguinal hernia is the most common type of hernia in both males as well as females. Now see the twist in the question. Femoral hernia is more common in females. So the most common type of hernia in females, indirect inguinal hernia, but femoral hernia, it is more common in females. More common in females. Simple. Now see the questions related to anatomy first. There is a deep ring and there is superficial ring. You know that deep ring is the defect in fascia transversalis and superficial ring is defect in external oblique aponeurosis. Deep ring, defect in fascia transversalis. Superficial ring, defect in external oblique aponeurosis. What is the difference between direct hernia and indirect inguinal hernia? In indirect inguinal hernia, the content is coming out from deep ring, traversing the inguinal canal, coming out via superficial ring. So it is indirectly coming into the inguinal canal. Direct hernia is coming directly into inguinal canal via triangle of Hazelbach. What are the boundaries of triangle of Hazelbach? Here you can see laterally there is inferior epigastric artery, this one. Okay. Medially you can see this is the rectus abdominis. Okay. So this is the lateral border of rectus abdominis and inferiorly there is inguinal ligament. So direct hernia is coming directly into inguinal canal via triangle of Hazelbach. Indirect hernia is coming indirectly via deep ring. Simple. Now see the question related to sac and neck of sac. This is the deep ring. Why this deep ring? Can you see the hernia content is coming out, right? So this is the cord and the hernia content is coming out. So if you see the relation, sac is anterolateral to the cord in indirect inguinal hernia. And in direct hernia, since the content is coming directly from posterior abdominal wall via triangle of Hazelbach, so in direct inguinal hernia, the sac is posterior. Two questions. What is the relation of sac? In indirect inguinal hernia, the sac is anterolateral to cord. Okay, and in direct inguinal hernia, the sac is posterior to cord. This is the relation with cord. Now the comparison of indirect inguinal hernia and femoral hernia. If you see, this is the sac of indirect inguinal hernia. Here, this is the neck of sac. What's this? Neck of sac. And what's the name of this tubercle? Pubic tubercle. So the neck of sac is located above and medial to pubic tubercle in indirect inguinal hernia, and neck of sac of femoral hernia. This is femoral hernia. Neck of sac of femoral hernia is located below and lateral to the pubic tubercle. So two important questions. Indirect inguinal hernia, sac is anterolateral to cord. In direct inguinal hernia, sac is posterior to the cord. In indirect inguinal hernia, neck of sac is located above and medial to pubic tubercle. In femoral hernia, neck of sac is located below and lateral to pubic tubercle. What are the types of indirect inguinal hernia? So you can see this is the deep ring, this is the superficial ring, and this part is what? Inguinal canal. First, what is bubonocele? So you can see here, in bubonocele, the hernia content is located into the inguinal canal. That's bubonocele. What is funicular? In funicular hernia, this processus vaginalis, it is closed just above epididymis. So here you can see, processus vaginalis is closed just above the epididymis. Complete hernia is also known as scrotal hernia. And if you see this type of hernia, testis appears to lie in the lower part of hernia, that is complete or scrotal. These are the types of indirect inguinal hernia. In hernia, important definitions are asked. So what is the reducible hernia? When the content can be reduced, it is reducible. And what is irreducible hernia? In certain patients, you can see that there is formation of adhesions between the sac and content. And if there is adhesion between sac and the content cannot be reduced, and this is irreducible hernia. Sometimes there is presence of fecal matter. What? Hernia cannot be reduced because of presence of fecal matter in the content or in the bowel. Because of fecal matter, if hernia cannot be reduced, it's known as incarcerated hernia. That's incarcerated hernia. Okay. After that, two terms are there. One is obstructed hernia and one is strangulated hernia. So whenever there is intestinal obstruction with preserved vascular supply, there is obstructed hernia. This is obstructed. And whenever there is intestinal obstruction with compromised vascular supply, that's strangulated. So in this picture, you can see there is gangrene of this content or bowel. So bowel is gangrenous. Its blood supply is compromised. So what kind of hernia? This is strangulated hernia. These are the various types of hernia. After that, depending upon the content also, we are going to label the hernia as enterocele or omentocele. Now imagine the situation. Here you can see the small intestine is the content. This is what? What's the name? This is enterocele. So when small intestine is the content, it's known as enterocele. And whenever omentum is the content, that's known as omentocele. Clear? What's the problem with enterocele? Whenever we are trying to reduce the enterocele, means when the content is small intestine, in this case, first part is difficult to reduce, but last part reduces easily with gurgling sound. First part difficult to reduce, last part reduces easily with gurgling sounds, and you can see the visible peristalsis, right? Omentocele, what's the problem here? Here first part is easy to reduce, last part is difficult to reduce, and here the content is dewy. The content is dewy. Okay, so first part, last part. In enterosyl first part, it's difficult to reduce. Omentosyl first part is easy to reduce. In enterosyl last part, reduces easily with gurgling sound. Clear? And in omentosyl last part, it's difficult to reduce. Simple. Difference between omentosyl and enterosyl. Imagine a situation where the content is appendix or it's Meckel's diverticulum. So here you can see the content is Meckel's diverticulum. What's the name? It's known as Litter's hernia. And here you can see the content is appendix. And whenever the content is appendix, it's known as what? Amyand's hernia. So Litter's hernia, Amyand's hernia. In clinical postings, you have seen that even final year students are going to make the diagnosis of hernia. How? On the basis of clinical examination only. So how we are going to make the diagnosis of hernia? Diagnosis of hernia is clinical. We don't need investigations. Diagnosis of hernia is clinical. But for clinical diagnosis, hernia should be either visible or palpable. There are certain exceptions like Spigelian hernia, internal hernia, where it's neither visible nor palpable. In such cases, we need investigations. So what are the exceptions? Exceptions where you cannot make the diagnosis clinically. This is asked in exam. First is Spigelian hernia and second is internal hernia. And how you're going to make the diagnosis of Spigelian hernia or internal hernia? Obviously with the help of investigations like ultrasound or CT. Now coming to the management. The management of hernia is having two components. First, the treatment of sac, and the second, inguinal floor reconstruction. In relation to treatment of sac, there are three terms which are frequently asked: herniotomy, herniorrhaphy, hernioplasty. What is herniorrhaphy? It is herniotomy plus inguinal floor strengthening with the help of sutures only. So herniotomy with inguinal floor strengthening with the help of sutures. And if with herniotomy we are going for application of mesh, that is hernioplasty. So this is herniotomy plus inguinal floor strengthening with help of mesh. Three terms. Inguinal floor reconstruction, it's further divided into three types. So you can see what are the types. One is primary tissue repair. What are the surgeries which are included and commonly asked? One is Bassini and second is Shouldes. So it's the Bassini's repair and Shouldes repair. Anterior tension free repair or anterior tension free mesh hernioplasty, and this is Liechtenstein repair. Liechtenstein is a place in Switzerland. So it's Liechtenstein repair. And what are the laparoscopic or pre-peritoneal repairs? It's TEP and TAPP. TEP is totally extraperitoneal and TAPP is trans-abdominal pre-peritoneal. One by one we are going to discuss. What happens in Bassini's? Bassini's repair is also known as triple layer repair. Why? See, these are the four layers in abdominal wall. This is external oblique, this is internal oblique, transversus abdominis, fascia transversalis. Okay, so what happens apart from external oblique? These are the three layers: internal oblique, transversus abdominis, fascia transversalis. We are going to suture these three layers together to the shelving edge of inguinal ligament, and it is known as what? Triple layer repair. So in this image you can see internal oblique, transversus abdominis, fascia transversalis. All these are sutured together to the shelving edge of inguinal ligament, and that's why Bassini's repair is also known as triple layer repair. What is the main problem with Bassini's repair? That when three layers are sutured together to the shelving edge of inguinal ligament, there is increased tension over the tissues, and because of this increased tension over the tissues, what's the problem? Recurrence. So because of increased tension over the tissues, it is associated with increased recurrence. The second repair is Sholdy's repair. So what we do in this case, this is fascia transversalis, we divide it and we perform double breasting of fascia transversalis. So see the layers, external oblique, internal oblique, transversus abdominis, fascia transversalis. Apart from external oblique 3 layers, we are going to perform the double breasting of fascia transversalis. So how many layers? 4 layered repair. So Sholdy's repair is 4 layered repair. Nowadays, even modified Sholdy's is done, in which we perform double breasting of internal oblique, transversus abdominis and fascia transversalis. So how many layered repair? 6 layered repair. Clear? So Sholdy's repair, we perform double breasting of fascia transversalis, and it's also known as 4 layered repair. It's known as 4 layered repair. Clear? There is modified Sholdy's. So what we do in modified Sholdy's, there is double breasting of internal oblique, transversus abdominis plus fascia transversalis, and this is what? It's 6 layered repair. This is 6 layered repair. In Sholdy's repair also, there is increased tension over the tissues, but it is lesser as compared to Bassini's, and that's why it's having lesser recurrence rate as compared to Bassini's repair. So see this list again. If you see the Lichtenstein repair, this is the gold standard treatment for hernia. For inguinal hernia, Lichtenstein repair is the gold standard treatment. Okay, and nowadays in private hospitals and tertiary centers, even TEP and TAPP is also done frequently. These are laparoscopic or pre-peritoneal repair. In relation to laparoscopic or pre-peritoneal repair, since it's performed commonly nowadays, lots and lots of questions are asked specifically related to landmarks during laparoscopic repair. The first landmark is triangle of Doom. What are the boundaries of triangle of Doom? So medially you can see this is what? Vas deferens. Laterally you can see this is gonadal vessels. Apex is formed by deep ring, and here this is the base. It is formed by peritoneum or peritoneal edge. Medially vas deferens, laterally gonadal vessel, base by peritoneal edge, and the apex by deep ring. See the content of triangle of Doom. There is iliac vein and there is iliac artery. So iliac vessels are the content, and what's the problem? These iliac vessels are hidden behind the fold of peritoneum. If surgeon is not very careful, sharp dissection in this region can lead to injury of these two vessels, leading to massive bleeding. That's why it's known as what? Triangle of Doom. So what's the precaution you have to take? In this region, we should not perform the sharp dissection, because sharp dissection can lead to injury of iliac vessels, which can lead to bleeding and death. The second landmark is triangle of Paine. Why it's known as triangle of Paine? First, see the boundaries. Here you can see medially there is gonadal vessels. Superiorly there is iliopubic tract. This is IPT, iliopubic tract, and laterally you can see there is peritoneum. These are the boundaries of triangle of Paine. If you see the content, there are 4 important nerves located in this region. If we see from medial to lateral direction, what are the nerves from medial to lateral? Femoral nerve. Second is femoral branch of genitofemoral nerve. Third, anterior cutaneous nerve of thigh. And fourth is lateral cutaneous nerve of thigh. So many nerves are there. That's why in this particular region, you should not use electrocautery, because use of electrocautery can lead to injury of nerves and it can lead to post-operative pain, and that's why what's the name? Triangle of Paine. It can lead to post-operative pain, so it's known as triangle of Paine. You have to remember the content. Out of these 4 nerves, which nerve is most commonly injured? It's the lateral cutaneous nerve of thigh. Most commonly injured nerve in laparoscopic hernia repair, that's lateral cutaneous nerve of thigh. Now see the one-liner question which was asked many times in NEET and DNB. Most commonly injured nerve we discussed in laparoscopic hernia repair is the lateral cutaneous nerve of thigh, right? And in open hernia repair, it is ilioinguinal. It's ilioinguinal. Sometimes it is not mentioned. Then it's iliohypogastric, iliohypogastric, hypogastric, followed by genital branch of genitofemoral nerve. Is the genital branch of genitofemoral nerve. How to remember? The mnemonic is GHI in reverse sequence. Okay. So most common I, ilioinguinal. Second most common H, iliohypogastric. And third is G, that is genital. So these are the nerves injured in hernia repair. Now third important landmark, it's known as corona mortis or crown of death. For corona mortis or crown of death, you have to understand a bit of anatomy. It's very easy to understand. Corona mortis or crown of death. Here you can see this is external iliac artery. So here you can see this is what internal iliac artery. Okay. Inferior epigastric artery, it's a branch of external iliac artery, and this obturator artery, it's a branch of internal iliac artery. There is no direct connection between these two arteries, obturator and inferior epigastric artery. Sometimes there is corona mortis artery. You can see this one. Corona mortis artery, that is also known as aberrant obturator artery. Corona mortis artery, also known as aberrant obturator artery, it's a branch of inferior epigastric artery and it attaches to obturator artery. So here you can see it forms a vascular loop, and because of formation of this vascular loop, there is increased risk of injury during mesh fixation and surgery. Clear? So during dissection and mesh fixation, there is increased risk of this aberrant obturator artery leading to bleeding and death, and that's why it's known as what? Crown of death, also known as corona mortis. Okay, so coronavirus is there, and another cause of death nowadays, yes, coronavirus. So this is corona mortis. It is because of aberrant obturator artery, and this aberrant obturator artery is the branch of inferior epigastric artery. So three landmarks you have to remember: triangle of doom, triangle of pain, and corona mortis. Now see the important questions related to strangulated hernia. First, the definition, that it is characterized by intestinal obstruction plus impaired vascular supply. So here you can see impaired vascular supply of the bowel. Okay. Second thing, that how you are going to make the diagnosis of strangulated hernia. So in hernia also we make the diagnosis by clinical examination, and in strangulated hernia also, the diagnosis is made by clinical examination. You have to remember clinical examination. Okay. Second, what is the constricting agent in strangulated hernia? And here you can see this is the constricting agent. What's that? It's the neck. So which part? It's the neck of hernia which acts as constricting agent. Where are we going to open the hernia in surgery? So incision should be given over the most prominent part. Where will you give incision? Over the most prominent part. And whenever we are going to open the fundus of sac, the suction should be ready. Why? Because there is fluid rich in bacteria, so we have to suck that fluid. Third, related to the treatment, that prosthetic mesh is contraindicated whenever there is strangulation, since there is increased risk of infection. What? Prosthetic mesh, it's contraindicated. We generally don't use mesh in strangulated hernia. But if you want to use mesh, you can use bioprosthetic or absorbable mesh. Which can be used? We can use bioprosthetic mesh or absorbable mesh. Clear? These are the important points related to strangulated hernia management. Now see the hernia which is more common in females and having high risk of strangulation. It's femoral hernia. So basic questions, we discussed that it's more common in females. It is more common on right side and it's bilateral in 20% cases. Generally, femoral hernia is more common in multipara females because of laxity of ligaments. See the important questions related to anatomy. If you see, this is the femoral ring and this canal is known as femoral canal. What's the diameter of femoral ring? It's 1.25 centimeter. And what's the length of femoral canal? 1.25 centimeter. Length of femoral canal 1.25 centimeter. Diameter of femoral ring 1.25 centimeter. And if you see relation, there is vein, artery, and this is nerve. So from medial to lateral, there is femoral vein, femoral artery, femoral nerve. So it's VAN. You know that there is a lymph node. Can you see here? The green colored lymph node. So this is known as Colquitt lymph node. There is lymph node in the femoral canal. Colquitt lymph node. So here you are going to realize that femoral canal is very narrow and rigid. And what happens whenever there is herniation, there is high risk of strangulation. That's why as early as possible after diagnosis, surgery is done. Surgery should be done as early as possible after diagnosis. Why? Because of increased risk of strangulation, because femoral canal is narrow and rigid. See the various approaches for repair of femoral hernia. There is Lockwood. Here we give subinguinal incision. The approach is dependent on the location of incision. So in Lockwood, we give subinguinal incision. In Lothian, we give inguinal incision. And in McEvedy, we give suprainguinal incision. Suprainguinal incision. So how to remember? Lockwood, Lothian, McEvedy, subinguinal, inguinal, suprainguinal. Nowadays, what is the treatment of choice? Is the Henry's procedure. You have to remember the name of surgery. It's the Henry's procedure, which is the treatment of choice for femoral hernia. Henry's procedure. See the variants of femoral hernia. These are one-liner questions asked frequently. First, Logier's hernia. So if you see the relation of this Logier's hernia, this is the lacunar ligament and this is the Logier's hernia. So whenever hernia is occurring through gap in lacunar ligament, how to remember? Logier's, lacunar, L for L. Hernia occurring through gap in lacunar ligament, it's Logier's hernia. Second is this Colquitt's hernia, and can you see its relation with pectineus? Right? So in Colquitt hernia, hernia is located behind pectineus fascia. It is located behind pectineus fascia. Third is Nareth hernia, and this Nareth hernia is seen in congenital dislocation of hip. So what happens in congenital dislocation of hip? There is lateral displacement of sac, and if sac is going to displace laterally, it comes in close relation to what? Femoral vessels. So whenever sac is located behind femoral vessels, this is Nareth hernia, and it is seen in patients of congenital dislocation of hip. What is Spigelian hernia? So hernia through Spigelian fascia. You can say this is this gray colored thing is Spigelian fascia. Hernia occurring through Spigelian fascia, that's Spigelian hernia. What's the location? It is infraumbilical, and most of the Spigelian hernias are located at or below arcuate line. In Bailey, it's wrongly written that it is located above arcuate line. It is located at or below arcuate line. Okay. This Spigelian hernia, it is also known as interparietal hernia. Why? Because here the content is located between external oblique and internal oblique. So when content is located between external oblique and internal oblique, this is interparietal. And since it is located beneath external oblique, generally it's neither visible nor palpable. If it's neither visible nor palpable, it's difficult to make the diagnosis. So how we are going to make the diagnosis of Spigelian hernia? This is the exception where the diagnosis is made by ultrasound or CT. So how we make the diagnosis? Ultrasound and CT. And how we treat it? Invert the content and close the defect. So the treatment is content inversion, invert the content and close the defect. This is sliding hernia, also known as hernia englised. What is the special feature here? Here you can see the posterior wall of sac, it's formed by viscera. In this case, posterior wall of sac is formed by viscera. In this diagram also you can see this is the anterior wall of sac, and here you can see the posterior wall of sac, it is formed by viscera. Here it's cecum. So posterior wall of sac is formed by viscera in sliding hernia or hernia inglicate. Hernia inglicate, it is more common in males. It is more common on left side. And if it is more common on left side, you tell me what's the most common content? Obviously, sigmoid colon. And what is the most common content on right side? Here you can see cecum. So overall, the most common content is sigmoid colon because it's more common on left side, and on right side you can see the most common content is what? Cecum. What's the problem? Whenever we are performing hernia surgery and we are not aware of this anomaly, there are high chances of injury of the viscera. So whenever it's diagnosed, how we are going to repair? See, here we are going to invert sac along with content. So sac along with content is inverted back and the defect is repaired. So we are going to repair the defect. Invert the sac along with content and repair the defect in sliding hernia, which is also known as hernia inglicate. In this image, you can see there is hernia in the lumbar region of posterior abdominal wall. So whenever there is hernia in the lumbar region of posterior abdominal wall, it's known as lumbar hernia. Lumbar hernia is more common on left side. It can be congenital or acquired. In 20% it is congenital, in 80% it's acquired. What's the cause? Whenever we give some incision, especially pyelolithotomy, yes, so in those cases there is increased risk of hernia. So it is acquired in 80% cases. Now there are two triangles which are asked in relation to lumbar hernia. One is superior triangle of Greenfeld and the second is inferior triangle of Pettit. In lumbar hernia, most of the herniations are occurring via this superior triangle of Greenfeld. Yes, and what are the boundaries? Here you can see superiorly there is this 12th rib. You see posteriorly there is paraspinal muscle and anteriorly there is a muscle, which one? Internal oblique. Most of hernia in lumbar region is occurring via this superior triangle of Greenfeld. There is a second triangle here. You can see this is inferior triangle of Pettit. So in this case, you can see anteriorly there is external oblique. Posteriorly, you can see this latissimus dorsi muscle, and inferiorly, you can see what? This is iliac crest. So this triangle is known as inferior triangle of Pettit. In lumbar hernia, most of the hernias are occurring via superior triangle of Greenfeld. What's the name of surgery which is done for lumbar hernia? It's the Daud's operation. Name of surgery for lumbar hernia, it's the Daud's operation. It's not the military operation, it's a surgical operation. Daud's operation for lumbar hernia. This is obturator hernia. What's the other name of obturator hernia? It's also known as skinny old lady hernia. Skinny old lady hernia, and it's also known as what? French hernia. So what are the risk factors? Skinny old lady means lean and thin patient, chronic malnutrition, elderly females, multipara patients, patients who are having constipation, which leads to increased intra-abdominal pressure. Here you can see in the obturator canal there is herniation of this small bowel. In obturator hernia, everything is related to obturator. So see, there is obturator canal. In obturator canal, there is obturator nerve and obturator vessels. Whenever there is herniation of bowel, what will happen? There is compression of obturator nerve. And if there is compression of obturator nerve, patient will complain of pain radiating along inner aspect of thigh. So there is pain along inner aspect of thigh radiating to ipsilateral knee joint. This is known as Horship-Romberg sign. And because of compression of obturator nerve, there is absence of obturator reflex. This is known as Hannington-Kiff sign. So the first is Horship-Romberg sign, pain along inner aspect of thigh radiating to ipsilateral knee joint because of compression of obturator nerve, and absence of obturator reflex because of compression of obturator nerve, and that's known as Hannington-Kiff sign. In this case also we have to perform the repair. Which approach? By posterior approach. So in obturator hernia, hernia is repaired by posterior approach. There are three terms which are asked. What is epigastric hernia? What is umbilical hernia? And what is paraumbilical hernia? See this diagram. Whenever herniation is occurring directly via umbilicus, So herniation occurring directly via umbilicus, that's known as what? Umbilical hernia. And whenever herniation is occurring within 2 centimeter around umbilicus, above, below, right side, left side, so within 2 centimeter around umbilicus, that is paraumbilical hernia. So here you can see this is paraumbilical hernia. And from xiphoid process till 2 centimeter of umbilicus, from xiphoid process till 2 centimeter of umbilicus, any hernia is known as what? Epigastric. So this is what? Epigastric hernia. Okay. So in first picture, in this picture, you can see herniation directly via umbilicus. This is umbilical. Here, it's not directly via umbilicus, but it's within 2 centimeter of umbilicus. This is paraumbilical hernia. And now we are going to discuss epigastric hernia. What are the various names of epigastric hernia? It is also known as epigastric lipoma because the content is fat. What kind of fat? Preperitoneal fat. And the second name is fatty hernia of linea alba. So where is the defect? You can see defect in linea alba. So there is a small defect in the linea alba, and because of that there is herniation of what? Preperitoneal fat. This fat is incarcerated, leading to ischemia, and because of that ischemia there is pain, and this pain is radiating to epigastrium. So whenever pain is radiating to epigastrium, this is the type of hernia which mimics peptic ulcer. Why? Pain radiates to epigastrium. Here treatment is very easy. Whatever the preperitoneal fat is herniated, we have to excise. So excise the fat and close the defect. Whenever the size of defect is more than 4 centimeter, we have to use the mesh. You have to remember the size. Size of defect more than 4 centimeter, use the mesh. Otherwise, excise the fat, close the defect. That's sufficient for epigastric hernia. So this is incisional hernia. Here you can see hernia following the surgery. This is incisional hernia, and this incisional hernia is also known as post-operative ventral wall hernia. What's the cause? It is caused by failure of fusion of tissues. So if there is failure of fusion of tissues in post-operative period, there is hernia. The name is incisional, so it is related to incision. In which particular incisions this hernia is more common? So if you compare upper abdominal or lower abdominal, more common in lower abdominal incision. Long incisions or short incisions, so long incisions. Midline incisions or paramedian incisions, so midline incision. Transverse or vertical incision, so vertical incisions. So in which incisions it is more common? Obviously long, midline, vertical, lower abdominal. So in which incisions it is more commonly associated? Long, midline, vertical, lower abdominal incisions. In a latest exam, there was one question related to European Hernia Society classification of incisional hernia. EHS, European Hernia Society classification of incisional hernia. So it is divided into two types, midline and lateral incisional hernia. The midline incisional hernia is further divided into M1 to M5. Lateral incisional hernia divided into L1 to L4. Okay, see what is M1? It is subxiphoidal. So what is the extent? From xiphoid till 3 centimeter below xiphoid process. So it is from xiphoid process till 3 centimeter below. M2 is epigastric hernia. And what is the extent? Here you can see this is umbilicus. Extent, it is from 3 centimeter below xiphoid till 3 centimeter above umbilicus. Epigastric hernia, 3 centimeter below xiphoid till 3 centimeter above umbilicus. This was the question which was asked, that umbilical incisional hernia is which type? M3. So M3 is umbilical, extent 3 centimeter above to 3 centimeter below umbilicus. So extent 3 centimeter above to 3 centimeter below umbilicus. M4, this is infraumbilical. So what's the extent? 3 centimeter below umbilicus. This is pubis. This is pubis. Okay. So 3 centimeter below umbilicus till 3 centimeter above pubis. And what is M5? This is suprapubic. So obviously it is 3 centimeter cranial within 3 centimeter cranial to the pubic region. So this is suprapubic. M1 to M5. Now see the lateral incisional hernia. This L1 is located in subcostal region. So this is subcostal. L1 is subcostal. L2 is flank. L3 is located in iliac region, and this is lumbar region. So this L4 is lumbar. L1 subcostal, L2 flank, L3 iliac, and L4 is lumbar. Okay. How to remember? Mnemonic. So the mnemonic is CU in suprapubic region. Okay. So what is M1? M1 is subxiphoidal. What is M2? E epigastric. What is M3? That is umbilical. What is M4? That is infraumbilical. And what is M5? That's suprapubic. You have to remember because this was asked in a latest exam. What is the preferred treatment option for incisional hernia? Laparoscopic repair is preferred over open hernia repair, and the treatment of choice is IPOM. For incisional hernia, what's the treatment of choice? It's IPOM, intraperitoneal onlay mesh repair. This condition is known as omphalocele or exomphalos. Almost every year there is one question, image-based question from this particular topic, abdominal wall defect. So here, intestine fails to return to abdominal cavity. And what is the problem here? It is covered by two layers. Here you can see peritoneum inside and amnion outside. Clear? So it is covered by two layers, amnion outside and peritoneum inside. How to remember? Mnemonic is PIN. So peritoneum is in, amnion outside, peritoneum is inside. What is the problem? It is actually associated with trisomy. Which trisomy is 13, 18, 21. The main problem with omphalocele or exomphalos is its associations with congenital malformations. And what's the most common malformation with which it is associated? Cardiovascular system. So the most common congenital malformation, yes, it's cardiovascular system. And it's the congenital malformation which is responsible for death in patients of omphalocele. And because of this congenital malformations only, there is poor prognosis. What? There is poor prognosis. The most commonly associated congenital abnormality is cardiovascular. One type of Wilms tumor, variant of Wilms tumor, which is associated with omphalocele, that's known as Beckwith-Wiedemann syndrome. The second abdominal wall defect is gastroschisis. In gastroschisis, the bowel is exposed. Despite of that, prognosis is good. Why? Because gastroschisis is not associated with congenital malformations. Omphalocele is associated. What's the name of this condition? This is gastroschisis. In the picture, you can see this is umbilical cord. So here you can see this is umbilical cord, normal. On the right side of umbilical cord, you can see the defect. So here you can notice that defect is on the right side. There is bowel which is exposed. So defect is on the right side of umbilical cord and there is exposed bowel. This is gastroschisis. Gastroschisis, it is associated with intestinal atresia sometimes. Intestinal atresia, but other congenital malformations are not there. So since it's not associated with other congenital malformations, that's why as compared to omphalocele, it's having good prognosis. So these are the two image-based questions which are frequently asked nowadays. What's the distribution of desmoid tumors? So you know it is extra-abdominal in 60% cases. It is arising from abdominal wall in 25% cases, and it is intra-abdominal in 15% cases. So overall, if we see the distribution, desmoid tumors are mainly extra-abdominal. We are going to discuss what abdominal wall desmoid tumor. Okay, what is the location? So generally abdominal wall desmoid tumors, these are infraumbilical arising from musculo-aponeurotic structures. What are the risk factors? If the person was having previous history of surgery, any kind of surgical incision, any kind of trauma, these are the risk factors. Estrogen exposure is a risk factor, that's why it's more common in females. So in this image you can see, because of surgery, after surgery, this patient developed tumor in infraumbilical region, which one? Desmoid tumor. So history of surgical incision or any trauma increases the risk. Estrogen is a risk factor, that's why desmoid tumors are more common in females, and there is one variant of FAP which is associated with desmoid tumors. Tell me the name. It's Gardner's syndrome. The name is Gardner's syndrome. Clear? The tumor is arising from musculo-aponeurotic structures. It means the origin is from soft tissue. That's why some of the features of this tumor is like sarcoma. Some of the features like investigation of choice for diagnosis, it's biopsy. Investigation of choice to see the extent of desmoid tumor, MRI. Treatment of choice, wide local excision with 2 cm margin. Clear? These are the similarities. But what's the good thing? That there is no sarcomatous change. There are certain similarities, but there are no sarcomatous changes seen in the tumor. There is no distant metastasis. What's the main problem of this tumor? The main problem of this tumor is what? Increased risk of recurrence. Increased risk of recurrence. That's why whenever we are performing wide local excision, we have to take 2 cm margin. What was the question in AIIMS related to desmoid tumor? That what's the most common presentation? And you can see the presentation. Most common presentation of desmoid tumor is the lump or mass. Lump or mass, this is the most common presentation. We discussed what is the investigation of choice for diagnosis. So investigation of choice for diagnosis, it's biopsy, and investigation of choice to assess the extent of desmoid tumor, MRI. For diagnosis, it's biopsy. For extent, it's MRI. There is increased risk of recurrence. We have to take 2 cm margin. Now imagine you perform the wide local excision and after that there is recurrence. So for recurrent desmoid, apart from surgery, we have to give radiotherapy. So how to treat desmoid tumors? Treatment is the wide local excision with 2 cm margin. Okay, and see the second question, recurrent desmoid. If in the question word recurrent is mentioned, recurrent desmoid, so here we go for surgery plus radiotherapy. Radiotherapy is not given to desmoid tumor, usually it's given for recurrent desmoids only. See the various named hernias which are asked as one-liner questions. So what is the Gibbons hernia? It's hernia plus hydrocele. Gibbons hernia, it's hernia plus hydrocele. What is Burgess hernia? When hernia is there into the pouch of Douglas. So Burgess hernia, it's hernia into pouch of Douglas. Pouch of Douglas. Okay. Beclard's hernia, whenever there is hernia through saphenous opening. So hernia through saphenous opening, that's Beclard's. Okay, and there are two terms. One is Ogilvie's syndrome and one is Ogilvie's hernia. What is Ogilvie's syndrome? We discussed idiopathic colonic pseudo-obstruction. That is Ogilvie's syndrome. And whenever there is hernia through the defect in conjoint tendon, that's Ogilvie's hernia. So in this case, there is hernia through defect in conjoint tendon. Defect in conjoint tendon. That's Ogilvie's. What is Stammer's hernia? So after retrocolic gastrojejunostomy, whenever herniation occurs through transverse mesocolon. So here, herniation through transverse mesocolon. Herniation through transverse mesocolon, after which surgery? After retrocolic gastrojejunostomy. Herniation through transverse mesocolon after retrocolic gastrojejunostomy, that's Stammer's. Peterson was asked many times in NEET and DNB. Peterson hernia occurs after bariatric surgery. Which one? Roux-en-Y gastric bypass. So this is occurring after Roux-en-Y gastric bypass, and in this case there is herniation behind Roux limb after Roux-en-Y gastric bypass. It is Peterson hernia. In this image you can see this Velpu's hernia is prevascular and this Serafini's hernia is retrovascular. So the hernia in which the sac is anterior to the femoral vessels, it is prevascular, and if it's located behind femoral vessels, that is retrovascular, and that's Serafini's. So Velpu's hernia, it's prevascular. So here sac is located in front of femoral vessels, and Serafini's hernia, it's retrovascular, and here the sac is located behind femoral vessels. Holt-House hernia is a type of inguinal hernia in which there is extension of bowel along the inguinal ligament. So in Holt-House hernia, there is extension of bowel along inguinal ligament. Okay, it's a type of inguinal hernia. So these are the named hernias. There is another hernia which is asked, that's Richter's hernia. So in Richter's hernia you can see there is herniation of part of circumference of bowel, and bowel is going to sense the obstruction. So what happens? There is hyperperistalsis. Because of hyperperistalsis, what happens? There is colicky pain and the contents are moving distally. So that's why this hernia is associated with what? Colicky pain. And since there is partial obstruction because of increased peristalsis, it's associated with diarrhea. So because of colicky pain and diarrhea, this condition mimics acute gastroenteritis. So this is the question which is asked, that which hernia mimics acute gastroenteritis? It's the Richter's hernia, in which there is herniation of part of circumference of bowel. So this is all about hernia. Now we are going to discuss kidney and ureter. In kidney and ureter, first we are going to discuss types of renal stones. So see the types of renal stones. First question, what's the most common type of renal stone? And that is calcium oxalate. So the most common type of renal stone is calcium oxalate. And you know, this calcium oxalate is radio opaque. So this is most common type of renal stone, and this is radio opaque. Okay. Second, what is the most common type of radiolucent renal stone? And the most common type of radiolucent renal stone is uric acid. It's the uric acid stone. This is the most common type of radiolucent renal stone. Okay, most common type of radiolucent renal stone. Now how these stones are formed? Hypoxanthine is converted into xanthine and xanthine is converted into uric acid. Both of these steps are blocked by allopurinol. So you know which drug is used here. In uric acid stone, we can use allopurinol. Why? Because hypoxanthine, it's converted into xanthine, and this xanthine, it's converted into uric acid. Clear? So you know both of these steps, conversion of hypoxanthine into xanthine and xanthine into uric acid, it's blocked by allopurinol. There is another question. Xanthine stones are seen in xanthinuria. So when hypoxanthine converts into xanthine, there is formation of xanthine stone. So this step is blocked by allopurinol. That's why allopurinol is also used in xanthine stones. Look at this stone. If you see, this stone is having branching and it looks like horn of stag. So stone is having branching. It looks like horn of stag. So the name of this stone is staghorn calculi. So what's the name? It's known as staghorn calculi. What are the other names of staghorn calculi? Struide stone, also known as triple phosphate stone, also known as calcium, magnesium, ammonium phosphate. Right? What's the problem in this stone? See, You know, females have short urethra of 4 centimeter. So females have increased risk of UTI because of short urethra, right? Now there is one organism, name of organism is Proteus. This Proteus, it produces urease, and this urease converts urea into ammonia, and that ammonia is precipitated here. So this Struide stone is more common in males or females? Females. What is the most common organism responsible? It's the Proteus, and it produces urease. Next is cystine stones, and these cystine stones are seen in cystinuria. Cystine stones, these are seen in cystinuria. You know that cystine stones are radio opaque. Why cystine stones are radio opaque? Because these stones are having double sulfur bond or disulfide bond. So it's having double sulfur bond or disulfide bond. Another important feature of cystine stone that the crystals are like this, hexagonal or benzene shaped. In cystine stones, benzene shaped or hexagonal crystals are there, and these stones are very hard. These are not easily broken by ESWL. Very hard stones, not easily broken by ESWL. For the medical management, we give certain drugs. What are the preferred drugs? Alpha mercaptopropionil glycine. Alpha mercaptopropionil glycine, it is preferred over D-penicillamine. These are the two drugs used. Alpha mercaptopropionil glycine, it is preferred over D-penicillamine. Both of these are used in cystine stones. Next is xanthine stone. Okay, and this xanthine stone, it is seen in xanthinuria, and we discussed that hypoxanthine, it is converted into xanthine. So there is formation of xanthine stone, and the drug which can block this step, what's the name? It's allopurinol. So here allopurinol can be used. Xanthine stones are radiolucent. See the color. Yes, this was the question in NEET. It is brick red. The color is brick red. And if you notice the stone, it is showing what? Lamination. Xanthine stones are brick red in color, and it shows lamination on cross section. So another important point, xanthine stones show lamination on cross section, and the color is brick red. The first question which is frequently asked related to renal stones is that which renal stones are radiolucent, and how to remember? The mnemonic is TICSU. TICSU is radiolucent. So tramterine, indinavir, xanthine and uric acid, these are radiolucent. Which stones are acidic? And the mnemonic to remember acidic stone is CCU. CCU is acidic. So calcium oxalate, cysteine and uric acid, these are acidic. TICSU is radiolucent. Now coming to the clinical features. First question, what is the most common symptom in renal stone? And you know the most common presentation is abdominal pain. Most common presentation, abdominal pain. Second important point, the radiation of pain depends on the location of stone. So here most common presentation is the abdominal pain, and radiation depends on the location. So imagine here, this is upper 1/3, this is middle 1/3, and this is lower 1/3 of ureter. Here is the stone. So whenever the stone is located in upper 1/3 of ureter, where is the radiation? In males, the pain radiates to testes, and in females, it radiates to labia majora. So important point, if it is in upper 1/3 of ureter, in males, it radiates to testis, and in females, it radiates to labia majora. Okay. Second situation, when the stone is in the middle 1/3 of ureter. Yes, here the pain radiates to iliac fossa, hypogastrium and groin. Radiation is to iliac fossa, hypogastrium and groin. So first question, this radiation is via which nerve? Pain radiates to iliac fossa, hypogastrium. So what's the nerve? Iliohypogastrium. Simple. So this radiation is via which nerve? Iliohypogastric nerve. First question. Suppose pain radiates to iliac fossa. So on right side, it mimics which condition? Acute appendicitis. On left side, it mimics which condition? Diverticulitis. So another question. On the right side, it mimics acute appendicitis. And on the left side, if the stone is in the left ureter, it mimics diverticulitis. Okay. Third situation is when the stone is in the lower 1/3 of ureter. Here, the pain radiates to scrotum, perineum, inner aspect of thigh. Via which nerve? Ilioinguinal nerve. So in this situation, pain radiates to scrotum, perineum, and inner aspect of thigh. Right? And it's via which nerve? It's via ilioinguinal nerve. This is via ilioinguinal nerve. This is the radiation. Sometimes the stone is stuck where? In the intramural ureter. And if the stone is stuck in intramural ureter, these patients have strangury. Strangury. So these are the manifestations of renal stones. So what is the investigation of choice for diagnosis? And the investigation of choice for diagnosis of acute ureteric colic, it's NCCT, non-contrast CT. What kind of? Spiral. So it is non-contrast spiral CT. It is non-contrast spiral CT, which is the investigation of choice. And what is the drug of choice? We give diclofenac and the brand name is Voveron. So for the management, we give diclofenac and the name is Voveron. We manage the patient. Meanwhile, we have to send the investigations. So what are the investigations done? We go for urine RM. Urine investigations done. Urine routine microscopy. Okay. What is the useful information you are going to get? Most important information, the crystals. And these are image based questions which are frequently asked. Second, we send urine culture sensitivity and you will be having idea of infection. UTI is there or not. So on the basis of urine RM, you will be having rough idea what kind of stone is there on the basis of crystals. This is one of the frequently asked image based question, and this question is asked almost every year. In this image, you can see this is the calcium oxalate dihydrate stone. See how it looks like. And if you see the shape of crystal, yes, this was asked in AIMS, this was asked in INICET. It is looking like envelope, also known as bipyramidal. So calcium oxalate dihydrate stones have envelope shaped crystals or bipyramidal crystals. This is calcium oxalate monohydrate stone. See the appearance. And if you see the crystals, it is looking like what? Dumbbell or hourglass shaped. So what? Dumbbell shaped crystals or hourglass shaped crystals. So these are seen in calcium oxalate monohydrate. There is one confusion in exam. If in the exam only calcium oxalate term is mentioned, monohydrate or dihydrate is not mentioned, you will assume that it is calcium oxalate dihydrate. If examiner wants to ask calcium oxalate monohydrate, examiner will specifically mention the word monohydrate. So in calcium oxalate monohydrate, dumbbell shaped or hourglass shaped crystals are seen. Here you can see the appearance of cystine stone. And what is the shape of crystal? The crystals are hexagonal. Yes, and it looks like what? Benzene. So it is hexagonal or benzene shaped crystals in cystine stones. This question was asked many times in NEET PG and DNB. This is the staghorn calculi. See the appearance on X-ray. Multiple branching in the stone looks like staghorn. And if you see the shape of crystals, it looks like coffin lid. So this is coffin lid crystal, which is seen in struite stone, also known as staghorn or triple phosphate stone. Here you can see round and smooth stones. And if you see the crystals of uric acid are multifaceted, like irregular plates or rosette shaped. So multifaceted irregular plates or rosette shaped crystals, these are seen in uric acid stone. In this image, you can see that there are needle shaped crystals, and these needle shaped crystals are seen in bruchite stones. So these are needle shaped crystals, and These needle-shaped crystals are seen in brushite stone. Okay, brushite stone. So these are the important image-based questions related to crystals of stones. Now first see three important informations. 90% of renal stones are radio opaque or radiolucent. So you know it is radio opaque. 90% of gallstones, you know it is radiolucent. And 80% of salivary gland stones, these are radio opaque. Okay, radio opaque. So question, X-ray KUB is useful in renal stones or not? Yes, because 90% of the renal stones are radio opaque. So we go for X-ray KUB. What is the problem with X-ray KUB? It will diagnose the stone, but it will not tell you anything about hydronephrosis. Okay, so stone is diagnosed. What is the screening investigation for hydronephrosis? And the screening investigation for hydronephrosis is ultrasound. The problem with ultrasound that it will not tell you exact site of obstruction and it will not tell you the renal function. So you want to know hydronephrosis, exact site of obstruction, renal function, and for that we go for IVP. So what are the informations available from IVP? First, hydronephrosis. Second, site of obstruction. So where is the obstruction? And renal function. It will give you rough idea about renal function. Now imagine a situation. Here is the obstruction. Okay. So there will be hydronephrosis proximal to the obstruction. So this part is dilated, this part is dilated. Dye will not go beyond this obstruction if it's complete obstruction. So by IVP, we are going to assess the proximal part of obstruction or distal part of obstruction. So by IVP, we are going to assess this proximal part of obstruction. This is the problem. If we want to assess the distal part of obstruction, we have to inject the dye via ureter and then it is going into the distal part of obstruction. What is the name of this investigation? This is known as retrograde pyelogram. So IVP, intravenous pyelogram, it is going to assess the proximal part of obstruction. RGP, that is retrograde pyelogram, it is going to assess the distal part of obstruction. There are two radionuclide scans which are frequently asked. One is DMSA scan, and the second is DTPA scan, Okay, what is the full form of DMSA? Dimercaptosuccinic acid scan. Dimercaptosuccinic acid scan. What is the use? Here, the term is self-explanatory. DMSA, M, it is used for assessment of renal morphology. S, scar, and SA, surface anatomy. So DMSA scan is used for assessment of renal morphology, surface anatomy or scar. That's why what is the use? It is used in chronic pyelonephritis because you know in chronic pyelonephritis there is scar in the kidney. So indirectly question is asked, what is the investigation of choice for diagnosis of chronic pyelonephritis? Since there is scar, it's the DMSA scan. Full form of DTPA scan, diethylene triamine pentaacetic acid scan. Diethylene triamine pentaacetic acid scan. How to remember? See, P. P means perfusion and function. So DTPA scan is investigation of choice for renal perfusion and function. So these are the battery of investigations which are performed in the patients of renal stone. If you have seen your friends and relatives who are having stone, in majority of cases you have observed that no intervention was required. Active intervention was not required. The patient was managed conservatively. Why? Because of size, mainly the size. So what are the indications of conservative management? Size should be up to 5 mm. Second, depending upon the type of stone, if it is acidic, we go for alkalinization of urine. And if it's basic stone, we go for acidification of urine. So what? Alkalinization or acidification of urine. You know, acid and alkali joins and forms the salt. salt is soluble and it is excreted in urine. When we take plenty amount of fluid, there is no precipitation of crystals, so no stone formation. So in conservative management, 4 to 6 liters of fluids per day, alkalinization or acidification of urine. What are the interventions done in renal stones? The interventions are ESWL. First is ESWL, extracorporeal shockwave lithotripsy. And this extracorporeal shockwave lithotripsy, it is curative in 85% of cases. Second is PCNL, percutaneous nephrolithotomy, and third is URS, ureteroscopy. Percutaneous nephrolithotomy and ureteroscopy, these are curative for rest of 15% stone. So ideally speaking, these two are not used frequently nowadays. Most commonly performed ESWL, and whatever the stones which are not removed by ESWL, you are going to notice that we are going to remove those stones by PCNL or by URS. Now see the important questions related to ESWL, extracorporeal shockwave lithotripsy. First, what's the gold standard lithotripter used? It's the Dornier unmodified HM3. The gold standard lithotripter is Dornier unmodified HM3. So how it works? There is shockwave induced tensile cracking. So here you can see the shockwave is being delivered to the stones. It leads to erosion and shattering, and because of erosion and shattering, the stone fragments are excreted into urine via ureter. Imagine a situation in which there is obstruction in the ureter and you perform ESWL. So what will happen? The stone fragments will be collected into the proximal part of ureter. Stone fragments are collected into this proximal part of ureter, and what's the name of this complication? This is known as Steenstrasse, also known as street of stones, also known as columnation of gravel. So name of this complication, it is Steenstrasse, also known as street of stones, street of stones, and it's also known as columnation of gravel, columnation of gravel. So that's why distal obstruction is relative contraindication for ESWL. Generally, ESWL is going to remove most of the stones, and what should be the size? Up to 2 centimeter. You have to remember two sizes. For ESWL, generally the size is up to 2 centimeter, and for ERCP, which is used to remove the CVD stone, the maximum size of stone removed is 1.5 centimeter. So ESWL removes the stone maximum size up to 2 centimeter and ERCP 1.5 centimeter. There are certain stones which are very hard, not easily broken by ESWL, frequently asked in exams. So what are the hard stones which are not easily broken by ESWL? And the mnemonic is BHC2. It's BHC2. B, bruchite, H, hydroxyapatite, C, cysteine, and C, calcium oxalate monohydrate. Bruchite, hydroxyapatite, cysteine, calcium oxalate monohydrate. This was asked in All India once, and this was asked in a state entrance exam. So all these are very hard, not easily broken by ESWL. In ESWL, we give shock waves. So what are the contraindications? Absolute contraindication. In pregnancy, you cannot deliver shock waves to abdomen. And second, if patient is having some kind of bleeding disorder and shock wave is delivered, there is increased risk of hematoma. So what are the two absolute contraindications? Absolute contraindications of ESWL. First is the pregnancy, and the second is bleeding disorder. It's the pregnancy and second is bleeding disorder. Okay, majority of stones we discussed, 85% stones can be easily treated by ESWL. The stones which are left can be treated by PCNL or URS. See how PCNL is done. So this is PCNL, percutaneous nephrolithotomy. Term is self-explanatory. Percutaneous means percutaneously. Via skin, we are going into calyx, and via calyx, we are entering into the kidney, breaking the stone, taking the fragments of stone out. So this is percutaneous nephrolithotomy. In percutaneous nephroorthotomy, means PCNL, the preferred approach is, here you can see, is the posterior calycial approach. What is the preferred approach? It's the posterior calycial approach. We discussed that the stones which cannot be treated by ESWL, you can treat those stones by PCNL. So in ESWL, the maximum size of stone was 2 centimeter. When it's more than 2 centimeter, we can treat it by PCNL. Distal obstruction is there. If patient is having UTI, hard stones like BHC2, bruchite, hydroxyapatite, cysteine, calcium oxalate monohydrate. If patient is having lower calycial stone, it's very difficult to remove the lower calycial stone by ESWL. So in that case also, you break the stone, remove it by PCNL. And Staghorn calculi. In this Staghorn calculi, we go for sandwich technique, and that is what? PCNL plus ESWL. That is PCNL plus ESWL. So all these are the indications of PCNL. What is the approach? It's the posterior calycial approach. Directly you are going into the kidney, breaking the stone, taking it out. So during this intervention, there is increased risk of bleeding. So what is the most common complication? Bleeding. And what is the most commonly injured organ? See the track. Pleura, followed by colon, followed by spleen. So 2 questions. First, what's the most common complication of PCNL? And the most common complication is bleeding. Second question, what is the most commonly injured organ? It's the pleura, followed by colon, followed by spleen. Okay, so you have to remember the complications. In this image, you can see that this is the ureteroscope. So we are going into the bladder. From the bladder, we are going to enter into ureter. Okay. It's a very fine instrument. So what's the problem? There is increased risk of perforation. So first question, in ureteroscopy, what's the most common complication? The most common complication of ureteroscopy, it's the ureteric perforation. Ureteric perforation. Okay. By this ureteroscopy, you are going to visualize the stone. You can visualize the pathology. And imagine if there is a stone, what you can take it out by Dormia basket. If there is some tumor, we can take the biopsy. After urological procedures, we have to insert the DJ stent, double J stent. Ureteroscopy is performed for that. And if some foreign body is left, sometimes the stent is broken, some foreign body is left, that can be removed also by URS. So these are the indications of URS. So see the indications. Indications of ureteroscopy: first, insertion of DJ stent after urological procedure, removal of ureteric stone, removal of any foreign body, and if there is urothelial tumor, it is used for taking biopsy. So let's revise quickly the management of renal stones. We discussed size up to 2 centimeter. What is the preferred intervention? ESWL. Size more than 2 centimeter. What we are going to perform? PCNL. If the patient is having hard stones like BHC2, bruchite, hydroxyapatite, cysteine, calcium oxalate monohydrate, here we go for PCNL. And if the patient is having Staghorn calculi, sandwich technique is done. Preferred. So sandwich technique means we are using both PCNL plus ESWL. This is how we manage the renal stones. See the management of ureteric stone. Management of ureteric stone is dependent on 2 features. First, what's the location and what's the size? If the location of tumor is in the proximal 1/3 or middle 1/3 of ureter, and the size is up to 1 centimeter, what is the preferred intervention? ESWL. It is preferred over URS. And if the size is more than 1 centimeter for ureteric stone, I'm talking about ureteric stone, size more than 1 centimeter, stone is located in upper or middle 1/3, preferred technique is URS. And any kind of stone located in distal 1/3, preferred treatment option is URS, that's ureteroscopy. So this is how we manage renal stones and ureteric stones. The one-liners which are frequently asked both in surgery and pathology. Have a look. First question, what's the most common organism responsible for emphysematous cholecystitis? Yes, and it is Clostridium perfringens or Clostridium welchii. Most common organism responsible for emphysematous cholecystitis, air producing organism, Clostridium perfringens, which is also known as Clostridium welchii, followed by E. coli. You know, Clostridium perfringens is an anaerobe. It's an anaerobe, and E. coli, it is an aerobe. So sometimes they ask most common aerobic organism responsible for emphysematous cholecystitis, then the answer will be E. coli. Second question, what is the most common organism responsible for emphysematous pyelonephritis? And here it is E. coli. Another question, what is the most common organism responsible for xanthogranulomatous pyelonephritis? And here the organism is Proteus, and we discussed that Proteus is associated with one stone. Which one? Staghorn calculi. So xanthogranulomatous pyelonephritis is associated with Staghorn calculi. If you see xanthogranulomatous cholecystitis, it is non-infectious condition. So what's the cause? It is caused by rupture of Rokitansky-Ushoff sinuses. So what's the cause? It's a non-infectious condition caused by rupture of Rokitansky-Ushoff sinuses. Frequently asked one-liner questions. There are two terms which are asked. One is perinephric abscess and the second is pyonephrosis. In the perinephric abscess, there is collection of pus around kidney. So this is what? This is perinephric abscess. Okay. And what will you find in perinephric abscess? Since there is abscess, so there will be fever. There is abscess, so there is pain and tenderness. So in patients of perinephric abscess, what are the clinical features? There is pain, there is tenderness, pain and tenderness, and there is fever. So around kidney, there is pain and tenderness, there is fever. Second term is pyonephrosis. Pyonephrosis means kidney is bag of pus. So in this case, the pus is collected where? Inside the kidney. Pus is collected inside the kidney. Here, what's the problem? Since pus is there, patient is having fever. Kidney function is almost lost. Erythropoietin production is decreased. There is anemia. And kidney is filled with pus. So there is mass in the loin. So what's the name of this condition? This is pyonephrosis. And in pyonephrosis, pus is filled inside the kidney. This is known as, kidney is bag of pus. So kidney is bag of pus. This is characterized by fever, there is anemia, and there is mass in loin. Fever, anemia, mass in loin. Okay, so perinephric abscess and pyonephrosis. Now we are going to discuss genitourinary tuberculosis. First question, what is the most common organism responsible? Mycobacterium tuberculosis. And you know, in tuberculosis, what is the primary organ involved? Lungs. From lungs, genitourinary organs are involved by hematogenous spread. So primary organ involved, that's lungs, and from lungs, what kind of spread? There is hematogenous spread, and via this hematogenous spread, there is involvement of genitourinary tract. Now see this diagram. This is the kidney, this is ureter, this is bladder, this is prostate, this is urethra. Okay, this is the vas deferens. What is the problem? By this hematogenous spread, two organs are primarily involved. What are those two organs? It's the kidney and prostate. So from this hematogenous spread, there is involvement of what? Kidney and prostate. Okay. So by this hematogenous spread, involvement of kidney and prostate is there. The rest of the organs are involved either by descent of infection or by ascent of infection. What do you mean by descent? So see, this is the descent of infection. So from kidney, the organism or infection goes to ureter. From ureter, it goes to bladder. So ureter and bladder are involved because of descent of infection. When infection is there in the prostate, from prostate, the infection reaches where? Vas deferens. So this is ascent of infection. Kidney, prostate, primarily involved after hematogenous blood, ureter bladder because of descent of infection, and vas deferens because of ascent of infection. In this diagram, you notice that testis is missing. Here, important question, that testis is spared. In genitourinary tuberculosis, testis is spared. Now coming to the clinical features, how we suspect. Apart from signs and symptoms of tuberculosis, what these patients are having increased frequency. So what is the earliest, most common symptom of genitourinary tuberculosis? You have to remember, it's the earliest and most common symptom. So earliest, most common symptom of genitourinary tuberculosis, it's increased frequency. Increased frequency. You know that in tuberculosis there is sterile pyuria. On urine RM there is presence of pus cells. On culture sensitivity there is no growth within 48 hours. So it is sterile pyuria. There are important questions related to pathophysiology. Have a look. So in relation to kidney and ureter, what's the problem in genitourinary tuberculosis? That there is calycial stenosis, or sometimes stenosis is located at pelvic-ureteric junction. Because of this stenosis, there is hydronephrosis, sometimes pyonephrosis. Actually speaking, there is caseous necrosis. So what happens here? Kidney is filled with cheesy material. So in this diagram, you can see that kidney is filled with cheesy material, and this kind of appearance, this is known as putty kidney. So when kidney is filled with cheesy material, this is known as putty kidney. Because of this putty kidney, on X-ray, you might find scattered calcification. So next stage is calcification, and calcified kidney is known as cement kidney. Calcified kidney is known as cement kidney. So in this image, you can see the kidney is calcified. And whenever there is non-functioning calcified kidney, what happens? This is known as autonephrectomy. So what are the sequence of events? Calycial stenosis or stenosis at PUJ followed by hydronephrosis, followed by caseous necrosis. Kidney is filled with cheesy material. It leads to calcification. Calcified kidney is known as cement kidney. Kidney is filled with cheesy material, that's known as putty kidney. And non-functioning calcified kidney, this is known as autonephrectomy. This is what? Autonephrectomy. There are two terms which are asked. Autonephrectomy, it is seen in genitourinary tuberculosis. Autosplenectomy is seen in sickle cell anemia. So see what are the changes seen in bladder. When we perform the cystoscopy, what is the initial sign? Is the pallor around ureteric orifice. So on cystoscopy, the initial sign is pallor around ureteric orifice. When the patient is having chronic genitourinary tuberculosis, what happens? The bladder is small and contracted, and this small and contracted bladder is known as thimble bladder. When the bladder is small and contracted, if you are going to visualize the ureteric orifice, it appears like golf hole, and that's known as golf hole ureteric orifice. So in this image, you can see that the bladder is small and contracted, looks like a thimble, and that's why what's the name? It is thimble bladder. Small contracted bladder. And in chronic cases, see the appearance of ureteric orifice. So it looks like golf hole. So the name is golf hole ureteric orifice. This is what? Golf hole ureteric orifice. These are the changes which are seen in bladder. What happens to prostate? Prostate is calcified, and because of that, it is hard and nodular. So problem with prostate, it's calcified, and that's why it becomes hard and nodular. Okay, what's the problem with vas deferens? This is the appearance of vas deferens. So there is beaded appearance of vas deferens, and there are multiple discharging sinuses via scrotum. This is characteristic feature of tuberculosis. What is this feature? Is the beaded appearance of vas deferens with multiple discharging sinuses. Multiple discharging sinuses via scrotum. Okay, these are the changes seen. We discussed testes is spared. Now coming to the investigations performed in genitourinary tuberculosis. We discussed perform or you go for urine RM, there is pus cells. You go for culture sensitivity, there is no growth within 48 hours. It means what? This is sterile pyuria. On laboratory investigation, there is sterile pyuria. See this appearance. This is the earliest sign seen on IVP. What is the earliest sign seen on IVP? It looks like moth has eaten the calyx. So on IVP, the earliest sign is moth eaten calyx. This is what? You can see the arrows. Moth eaten calyx. This is the earliest sign. Now see the twist in the question. There are two questions which are asked frequently. First, what is the investigation of choice to detect early changes in the renal tuberculosis? That is IVP. And what is the investigation of choice for diagnosis of renal tuberculosis? That is CCT. So two questions. Investigation of choice for diagnosis of early changes in renal tuberculosis, and that's what? IVP. What is the earliest sign? Moth eaten calyx. An investigation of choice for diagnosis of renal tuberculosis, and that is what? That is CCT. Read the question carefully. Depending upon the language of the question, you have to mark the correct answer. How we manage genitourinary tuberculosis? First, we have to give ATT, and second, we have to manage the complications. So management includes ATT, anti-tubercular treatment, plus management of complications. Anti-tubercular treatment plus management of complications. See how we manage the complications. If there is ureteric stricture, obviously what we try? We try dilatation. There is small contracted bladder, that's known as thimble bladder. So increase the capacity, that is known as augmentation. How? By enterocystoplasty. So if there is small contracted bladder, we go for augmentation. Augmentation, enterocystoplasty. Okay, this is augmentation, enterocystoplasty. If there is non-functioning kidney, obviously what you have to go for? Nephrectomy. Non-functioning kidney, remove the kidney. We go for nephrectomy. Sometimes there is presence of non-dilatable stricture in the lower third of ureter, and in such cases we go for Bouary's operation. So in this picture you can see in the distal third there is non-dilatable stricture, so that part is excised, and we are going to raise a flap from bladder, that's known as Bouary's flap, and we are going to perform the anastomosis between the flap and ureter. So what's the name of this operation? This is Bouary's operation. Bouary's operation, and the name of flap is Bouary's flap. So this is how we manage the complications of genitourinary tuberculosis. Now we are going to discuss the renal tumors. First, benign renal tumors. Angiomyolipoma, benign tumor, composed of angio means blood vessel, myo means muscle, lipoma means fat. So it's the benign tumor composed of matured blood vessel, muscle, fat. You know, angiomyolipoma, it is the more common in females. Generally, it's single and unilateral. Generally, it is associated with one condition. It was asked many times in names. What's the name of that condition? It's tuberous sclerosis. And if it is seen in tuberous sclerosis, generally it is multiple and bilateral. Now see the questions related to pathology. In angiomyolipoma, on immunohistochemistry, there is positivity for HMB45. You know, HMB45 is positive in angiomyolipoma as well as malignant melanoma. Second feature, there is presence of macroaneurysm. And because of this macroaneurysm, in 10% cases, there is retroperitoneal hemorrhage. In 10% cases, retroperitoneal hemorrhage. What's the name of this condition? This is known as Wunderlich syndrome. It's known as Wunderlich syndrome, the retroperitoneal hemorrhage seen in angiomyolipoma. Now one basic question is there. What is the investigation of choice for most of the renal tumors? And that is CCT. Exception, Wilms. See, one important feature of renal tumors that the investigation of choice for most of the renal tumors is CCT. Exception Wilms. In Wilms, the investigation of choice for diagnosis is MRI, because MRI is having better soft tissue delineation. So in angiomyolipoma also, what's the investigation of choice for diagnosis? Yes, it is CCT. Whenever we are performing CT for renal tumors, we have to first rule out RCC and make the diagnosis. So here, what are the features which are going to differentiate angiomyolipoma from RCC? Here, there is presence of lipoma, means fat, and absence of calcification. So presence of fat, absence of calcification differentiate angiomyolipoma from RCC. Image-based questions are frequently asked related to angiomyolipoma. In this CT, you can see these are the areas which are relatively black. So this is presence of fat, which is seen in angiomyolipoma. So these are the tumors having fat looking relatively black. So this is angiomyolipoma. Now coming to the treatment. If the tumor is asymptomatic and the size of tumor is up to 4 centimeter, what we go for? Observation. And if the tumor is symptomatic and the size is more than 4 centimeter, here we go for partial nephrectomy, and that's known as nephron sparing surgery. Partial nephrectomy known as nephron sparing surgery. Renal oncocytoma. Oncocytoma, it means this tumor arises from oncocytes, and it mimics the eosinophilic variant of chromophobe RCC. Which variant? It mimics eosinophilic variant of chromophobe RCC. Okay. See, investigation of choice for diagnosis is CCT we discussed. See the gross appearance of tumor. This is the gross appearance of tumor, and in this tumor you can see there is presence of central stellate scar. So when we perform the CT, on CT also you are going to find that central stellate scar. So investigation of choice for diagnosis, that is CCT. And what is the appearance on this CCT? Characteristic appearance, you are going to find central stellate scar, right? Central stellate scar. In surgery, there are 4 tumors where this central stellate scar is seen and commonly asked in exam. So in which condition central stellate scar is seen? So central stellate scar, it is seen in first FNH, that is focal nodular hyperplasia. Second is fibrolamellar variant of HCC. Fibrolamellar variant of HCC. Third is serous cyst adenoma pancreas. Serous cyst adenoma pancreas. And the fourth is renal oncocytoma. It's the renal oncocytoma. So in these 4 conditions, we are going to find central stellate scar. Renal oncocytoma is benign tumor, so this is also managed by partial nephrectomy, that's known as nephron sparing surgery. Now we are going to discuss the pathological aspect of renal cell carcinoma. Okay, first question, what is the most common variant of RCC? And the most common variant is clear cell variant. This is the most common type. Is the clear cell variant. It arises from PCT. Most common type arises from PCT. Which gene mutation is responsible for clear cell variant? And that's VHL gene. And this VHL gene is located on chromosome number 3. And on chromosome number 3, there are 2 processes which are going to occur. One is deletion and the second is translocation. You know, for translocation 2 chromosomes are required. So one is 3. What are the other sets? So it is 3, 6, 3, 8, 3, 11. 3, 6, 3, 8, 3, 11. Clear cell, most common variant arising from PCT. Second is papillary variant. What is the similarity between clear cell variant and papillary variant? That both of these are going to arise from PCT, proximal convoluted tubule. Papillary variant is the most common type of RCC seen in patients of cystic disease requiring hemodialysis. Patients of cystic disease requiring hemodialysis. What's the name of gene mutated? It's the MET gene. And this MET gene is located on chromosome number 7. And on this chromosome number 7, which process is going to occur is the trisomy. We discussed that in papillary variant of RCC, there is dystrophic calcification. So what else we are going to find here? We are going to find Samoma bodies because of dystrophic calcification. Third is chromophobe variant. Chromophobe. Important question related to this chromophobe variant, that this is the variant which is having best prognosis. It arises from intercalated cells of collecting duct, and this is having plant cell appearance. Three important points related to chromophobe: arises from intercalated cells of collecting duct. First. Second, it's having best prognosis. And what kind of appearance? Yes, there is plant cell appearance. It's having plant cell appearance. And what's going to happen in chromophobe variant? There are multiple chromosome losses with extreme hypodiploidy. You have to remember the term. In this case, there are multiple chromosome losses leading to extreme hypodiploidy. Extreme hypodiploidy. There is a rare variant known as Bellini duct carcinoma. This Bellini duct carcinoma arises from collecting duct. It's rare. There is Hobnell pattern and desmoplastic reaction. This Bellini duct carcinoma, it arises from collecting duct. First question, rare, it's having Hobnell pattern, and there is desmoplastic reaction. So it is having desmoplastic reaction. Clear? These are the variant. In JIPMER, there was one question that what is the most common type of RCC exclusively seen in children suffering from sickle cell trait, and that is medullary variant. So have a look of 4 commonly asked questions related to RCC. Most common variant of RCC, clear cell. It's clear cell. Most common type seen in patients of cystic disease requiring hemodialysis, that's papillary. Papillary. Which one is having best prognosis? This is chromophobe. Best prognosis seen in chromophobe, and exclusively seen in children suffering from or with sickle cell trait. This is medullary variant. Medullary. These are the 4 important questions asked in relation to RCC. Now see the surgical aspect of RCC. What are the various names of RCC? Since it is arising from upper pole, known as hypernephroma, also known as Gravit's tumor, radiologist tumor, internist tumor. You know, RCC is the most common malignancy of kidney. It's the most common malignancy of kidney. Right? Generally seen in males, more common in males, seen in 6th to 7th decade. What are the risk factors? So you can see smoking, tobacco, analgesic nephropathy, or if there is exposure of cadmium or asbestos, all these are the risk factors. See the clinical features. It is characterized by a triad. What are the components of triad? There is mass, there is pain, and there is hematuria. Triad is mass, pain, hematuria. So first question, out of this triad, which one is most common symptom? It's the hematuria. Okay. What's the name of this triad? This triad is seen only in 10% patients having advanced disease. And that's why the name of this triad is too late triad. What's the name of this triad? Too late triad, because it is seen only in 10% patients who are having advanced disease. In RCC, what is the most common route of spread? Hematogenous. What is the most common site of metastasis? Lungs. And in lungs, you are going to see the cannonball secondaries. See, these are the cannonballs. And on X-ray also you can see cannonball secondaries. On CT also you can find cannonball secondaries. These X-rays are frequently asked. So most common route of spread, hematogenous. Most common site of metastasis, lungs. And in lungs, what kind of secondaries? Cannonball secondaries. There is another important point related to metastasis. See, what is the most common malignancy responsible for osteoblastic and osteolytic secondaries in males? Most common malignancy responsible for osteoblastic and osteolytic secondaries in males. If we see osteoblastic secondaries, it is because of carcinoma prostate. And if we see osteolytic secondaries, it is because of RCC. So one thing is clear, in RCC there is osteolytic secondaries and these are hypervascular. So these hypervascular osteolytic secondaries are also known as pulsatile secondaries. So the name of this secondaries, this is pulsatile secondaries. Not only in RCC, these pulsatile secondaries are also seen in follicular carcinoma thyroid. So again important question, pulsatile secondaries are seen in RCC and follicular carcinoma thyroid. See the paraneoplastic manifestations. What is the most common paraneoplastic manifestation of RCC? Yes, it is raised ESR. You have to remember. It is raised ESR. Most common paraneoplastic manifestation of RCC. Now coming to the investigations. We discussed that investigation of choice for diagnosis of most of the renal tumors, it is CCT. So in RCC also, investigation of choice for diagnosis CCT. See the twist. Investigation of choice for detecting tumor thrombus, because RCC is having property of vascular invasion. So it is going to invade renal vein. Via renal vein, it goes to IVC, and from IVC the tumor thrombus can reach to right atrium. So which investigation differentiates bland thrombus from tumor thrombus? It's MRI. MRI is investigation of choice for detecting tumor thrombus. And the question is gold standard investigation for IVC invasion, and this is inferior vena cava gram. Name of investigation? Inferior vena cava gram. These are the investigations related to RCC. Now coming to the management, there are two options you are going to get in these patients. One, that patient is having localized RCC. Even if patient is having localized RCC or patient is having locally advanced or metastatic RCC, right? What we have to go for? We have to go for radical nephrectomy. So in majority of cases, what you have to go for? Radical nephrectomy. There are certain special situations. Let's first discuss the advanced and metastatic RCC. In advanced and metastatic RCC, apart from radical nephrectomy, what's the first line agent given? It is the sunitinib. First line agent given in advanced and metastatic RCC, that is sunitinib. There is another special situation that in certain patients who are having localized RCC, we go for nephron sparing surgery, that's also known as partial nephrectomy. So what are those indications? Have a look. First, size of RCC up to 4 cm. This is established indication. We can do it in patients who are having size of 7 cm tumor also, but the established indication is 4 cm. If there is single kidney, patient is having single kidney and there is RCC, or patient is having bilateral RCC, or patient is having RCC with diseased contralateral kidney, like patient is having renal artery stenosis in which function can be lost anytime. So these are the indications where we perform nephron sparing surgery. In urology, there are named stagings and gradings which are asked. First, Robson staging and Fuhrman grading. It is used for RCC. Jackson staging, this is used for carcinoma penis, and Gleason grading, This is used for carcinoma prostate. Okay. So Robson staging, Fuhrman's grading RCC, Jackson staging carcinoma penis, Gleason grading carcinoma prostate. Before discussing Wilms tumor, let's discuss pediatric tumors first. So question is, what is the most common malignancy of infancy? Neuroblastoma. What is the most common intra-abdominal malignancy in children? Neuroblastoma. And what is the most common extracranial solid malignancy? Neuroblastoma. So in all these three cases, the answer is neuroblastoma. Okay. Another question. What is the second most common intra-abdominal malignancy in children? And the most common primary renal malignancy. And here the answer is Wilms tumor. Wilms tumor. Another question. What is the most common renal tumor of infancy? And if it's most common renal tumor of infancy, it's the congenital mesoblastic nephroma. It is congenital mesoblastic nephroma. Okay. Most common soft tissue tumor in children, you know, it's a type of sarcoma. What's the name? Rhabdomyosarcoma. These two questions are frequently asked. What is the most common malignancy in childhood overall? That's leukemia. And which type of leukemia? ALL. Most common type of malignancy in children, or most common malignancy of childhood, is leukemia. Which one? ALL. And if the question is asked most common solid malignancy of childhood, then it's brain tumor. Right? So if we see incidence, overall, the most common malignancy of childhood is leukemia, that's ALL, followed by brain tumor. These are the important one-liner questions. Now we are going to discuss Wilms. Wilms tumor is also known as nephroblastoma. What? Nephroblastoma. We discussed it's the most common primary renal malignancy of childhood, and it's the second most common intra-abdominal malignancy. In which particular age group it is seen? 2 to 5 years. And generally this is unilateral. What are the genes involved for Wilms tumor? It's WT1 and WT2, and both of these genes are located on chromosome number 11. Question is asked in pathology related to components of Wilms, and the mnemonic is BEST. Three components: blastema, epithelium, and stroma. There is one question which is asked in pathology, surgery, medicine, pediatrics. What? The variants of Wilms tumor. So one is Vagar syndrome, Dennis-Drash syndrome, Beckwith-Wiedemann syndrome. See the characteristic features of these variants. Now see the components of Vagar. WAGR. So it's Wilms tumor, aniridia, genital anomalies, and mental retardation. What kind of mental retardation? Second is Dennis-Drash syndrome. In Dennis-Drash syndrome, there is gonadal dysgenesis. What kind of? Pseudohermaphroditism. What kind of? It's the male pseudohermaphroditism, and there is renal failure. So in this Dennis-Drash syndrome, there is gonadal dysgenesis, and that's male pseudohermaphroditism and renal failure. There is renal failure. Third, which is most important, frequently asked in AIIMS, Beckwith-Wiedemann syndrome. In Beckwith-Wiedemann syndrome, there is hemihypertrophy, visceromegaly, means splenomegaly and hepatomegaly. There is enlarged tongue, that is macroglossia. There is omphalocele and hepatoblastoma, the liver tumor. So these are the features of Beckwith-Wiedemann syndrome. Now see the clinical features of Wilms tumor. We discussed the triad of RCC, and it was mass, pain, hematuria. Here also there is mass. Here at the place of pain, fever is there, and hematuria, what kind of? Microscopic. What kind of? Is the microscopic hematuria. This is the triad. Pain is there in Wilms tumor, pain is there in RCC. In both, pain is there, but pain is not the component of triad of Wilms. At the place of pain, there is fever. And what's the most common presentation of Wilms? It's mass. What was the most common presentation of RCC we discussed? Hematuria. These are the differences. Similarities, here also hematogenous spread is there. Most common route of spread is hematogenous, so most common site of metastasis is lungs. Investigation of choice is a bit different because in this case, in Wilms tumor, the investigation of choice for diagnosis is MRI. MRI is preferred over CT for better soft tissue details. How we are going to manage? Obviously, the treatment is also similar. It's a malignant tumor. So we go for radical nephrectomy. In this case also we go for radical nephrectomy. We discussed one question that in majority of malignancies, most important prognostic factor is stage, exception Wilms tumor and soft tissue sarcoma. In Wilms tumor, the most important prognostic factor is histology followed by stage. In soft tissue sarcoma, it's the tumor grade. So whenever we perform the radical nephrectomy, we send the specimen to pathology department. Then we get the report. If histological features are good, we are not going to do anything. And if histological features are adverse, so in cases of adverse histological features, we have to start chemotherapy and radiotherapy. Chemotherapy should be started within 5 days and radiotherapy within 10 days. This is important question. But in cases of adverse histological features, so start chemotherapy within 5 days, chemo within 5 days, and radiotherapy within 10 days. Within 10 days. You have to remember the duration also, 5 days, 10 days. So this is how we manage patients of Wilms tumor. Now we are going to discuss ADPKD, autosomal dominant polycystic kidney disease. So this is autosomal dominant, and what happens? Bilateral kidneys are replaced by multiple cysts. You can see here, both kidneys are replaced by multiple cysts. There is involvement of 2 chromosomes. What are the chromosomes involved? Chromosome number 16 and 4. What is the name of abnormal protein? It's the polycystin. It's the polycystin. Over a period of time, kidney loses its function of concentration, and that's why the patients are having what? Polyuria. Patients are having nocturia. There is increased risk of infection, so there is hematuria, stone. Apart from that, because of these cysts, what happens? There is compression of vessels, so there is activation of renin-angiotensin system, and because of that, there is hypertension. Hypertension is the most common presentation of ADPKD. I'm repeating, very important. Hypertension is the most common presentation of ADPKD. It is seen in 75% of adults and 25% of children. 75% of adults, 25% of children have hypertension. 2 important questions. Over a period of time, what happens? Patient is going to develop renal failure, and this renal failure patient is going to develop in 5th to 6th decade. For renal failure, we go for hemodialysis, and if kidney is available, we can go for renal transplantation. The question which is asked frequently, what's the most common cause of death? It's not the renal failure, it's the cardiovascular disorders. Cardiovascular disorders are the most common cause of death. And over a period of time, generally in 5th to 6th decade, patient develops chronic renal failure. So in management, what we do for chronic renal failure? 2 options. Either we can go for hemodialysis, and if kidney is available, what is the treatment of choice? It's the renal transplantation. Another important point, what is the most common extra-renal manifestation of ADPKD? And that is polycystic liver disease. It's the polycystic liver disease, multiple cysts in the liver. Investigation of choice for diagnosis of ADPKD, it is CCT. Investigation of choice is CCT. But if we perform IVP, what is the appearance? In this IVP, you can see that there is spider leg appearance. Here you can see it is also known as bell shape, bubble appearance, or Swiss cheese appearance. So these are seen on IVP, but the investigation of choice for diagnosis, that is CCT. We discussed what is the treatment of choice. It's the renal transplantation. Some surgeons previously they were just performing the de-roofing of the cyst, and de-roofing of the cyst is known as Rovsing's operation. There are three terms: Rovsing's operation, Rovsing syndrome, and Rovsing sign. So what we do in Rovsing's operation, which is performed for ADPKD, yes, in this case we perform the de-roofing of cyst. Is the de-roofing of cyst. What is Rovsing syndrome? In patients of horseshoe kidney, what happens? Hyperextension of spine leads to nausea, vomiting, and abdominal pain. So in horseshoe kidney, on hyperextension of spine, there is abdominal pain, there is nausea and vomiting. This is known as Rovsing syndrome, and we discussed in acute appendicitis that on pressing left iliac fossa, there is pain in right iliac fossa. This is the most specific sign of acute appendicitis. So this is Rovsing sign. On pressing left iliac fossa, there is pain in right iliac fossa. In which patients? In the patients of acute appendicitis. Clear? So that is Rovsing's sign. It's the most specific sign for acute appendicitis. These are the three important questions frequently asked. See this image here. There is obstruction at pelviureteric junction. So this is PUJ obstruction. It's the PUJ obstruction. Important questions. Generally, this PUJ obstruction, it's unilateral, more common in boys and more common on left side. Unilateral, it is common on left side and it is more common in boys. What is the problem? Because of this obstruction, there will be hydronephrosis. So obviously, these patients have unilateral hydronephrosis, right? That's why, because of this unilateral hydronephrosis, there is asymptomatic palpable intra-abdominal mass. So what's the problem? Palpable mass. And generally, these are asymptomatic. Why? Because it's unilateral. What is the investigation of choice for PUJ obstruction? It is DTPA scan. It's the DTPA scan. What's the gold standard treatment? That is Anderson-Hines dismembered pyeloplasty, in which we are going to excise the site of obstruction and perform end-to-end anastomosis. So name of this surgery, it is Anderson-Hines dismembered pyeloplasty. Dismembered pyeloplasty. This is the gold standard treatment for PUJ obstruction. In this image, you can see embryologically normal ureter is entrapped behind IVC. So what's the name? It's known as retrocaval ureter. Name of this condition, retrocaval ureter, also known as circumcaval ureter. Retrocaval ureter, also known as circumcaval ureter. So what's the problem here? Embryologically normal ureter is entrapped behind IVC. Question: it is because of abnormal persistence of its structure. It's because of abnormal persistence of right posterior subcardinal vein. This question was asked in NEET PG. Abnormal persistence of right posterior subcardinal vein. Because of this, there is symptoms of obstruction. So patients are going to have hydronephrosis, sometimes hydroureteronephrosis. What is the investigation of choice for diagnosis? Investigation of choice for diagnosis is MRI, right? What is the appearance on IVP? So here you can see this is the appearance on IVP. So this is what? This appearance, this is reverse J, also known as fish hook, also known as Shepherd Crook appearance. And what we do in the treatment, we are going to excise the ureter. This part is divided and then we perform the anastomosis. So this is what? Relocation ureterosterostomy. So investigation of choice, MRI. Treatment of choice, it is the relocation ureterosterostomy. This is horseshoe kidney. How much is the incidence? It is 1 in 400 live births. Okay, see the problem. This is the inferior mesenteric artery. This inferior mesenteric artery prevents the ascent of kidney. What's the level of inferior mesenteric artery? L2. This is the isthmus. So what is the level of isthmus? This is L3, L4. The axis of kidney remains vertical. There is vertical axis, And in this case, there is a special feature. What you are going to notice that there is presence of medial calyx. So axis is vertical and you will find medial calyx in horseshoe kidney. Medial calyx. Because of abnormal vascularity of horseshoe kidney, what is the investigation of choice? It's the CT angio. If CT angio is not mentioned in option, you go for CT. So investigation of choice for diagnosis is CT angio. What are the typical appearances seen on IVP? So on IVP, you can see there is medial orientation of calyx. This is known as hand joining sign. And there is higher insertion of ureter with anterior transposition, and this is known as what? Flower vase like curve of ureter. So two important signs, one is hand joining sign and second is flower vase like curve of ureter. These are seen on IVP. What is the treatment? If patient is going to develop any complication, we have to treat that complication. There was one question in NEET PG that if the patient is having Staghorn calculi, a patient of horseshoe kidney is having Staghorn calculi, which technique is preferred? So in this case, we go for PCNL. So what we do in the management of complications, if there is Staghorn calculi, which treatment strategy is preferred? PCNL. Isthmus should not be divided in patients of horseshoe kidney. This is ureterocele. What is ureterocele? It's the cystic dilatation of terminal part of ureter. Generally, this ureterocele, it's more common in females. What are the types? First, it's intravesical and second is ectopic. If it's in the bladder, intravesical, and if the opening is outside bladder, it is ectopic. Which one is more common? If you say intravesical, it's responsible for 20% cases. Ectopic, it's responsible for 80% cases. If you look the second picture carefully, you are going to notice that this ectopic ureterocele, it is associated with what? Duplication of ureter. Duplication of ureter. Okay, and generally this ureterocele is present in which pole ureter, upper pole or lower pole ureter? So you can see this is upper pole ureter which is having ureterocele. So intravesical, ectopic, which one is more common? Ectopic ureterocele. Because of this obstruction caused by ureterocele, you can see there is hydroureteronephrosis. These patients are having recurrent attacks of infection. If you are going to perform ultrasound, since there is hydroureteronephrosis, you will find hydroureteronephrosis. So on ultrasound, we'll get hydroureteronephrosis. Second, we get this cyst. So we see this cyst on ultrasound. On ultrasound, there is cyst with hydroureteronephrosis. And what's the investigation of choice for diagnosis? It is IVP. So here you can see this patient is having bilateral ureterocele. So you are going to notice that this patient is having bilateral hydroureteronephrosis, and the most important feature is this one, the appearance. So it looks like adder head or cobra head appearance. So on IVP in ureterocele, which appearance is seen? This is known as adder head or cobra head appearance. Now coming to the treatment. In intravesical, what you do? You perform the incision over cyst wall, so obstruction is relieved. And in ectopic variety, we are going to excise it, and after excision, we are going to re-implant it into the bladder. So in intravesical, incision over the cyst wall. In ectopic, excision with re-implantation into the bladder. This is the treatment of ureterocele. Important question which is frequently asked: most common congenital abnormality of upper urinary tract and urogenital tract. If we see the upper urinary tract, the most common congenital abnormality is duplication of ureter. Is the duplication. And if we see the whole urogenital tract, this is vesicoureteric reflux. So most common congenital abnormality of upper urinary tract, duplication of ureter. Urogenital tract, VUR. What is the similarity between these two? Similarity is that both duplication of ureter as well as VUR are autosomal dominant. This is the duplication of ureter, and you know this is autosomal dominant. Second, it is bilateral, and third, it's more common in females. What are the types? This is normal side, and this patient is having duplication. Here you can see the right kidney, there is incomplete duplication. Means there is duplication of ureter, but both of ureters are going to join before draining into the bladder. This is known as incomplete duplication. And what's the other name of this incomplete duplication? It is also known as bifid ureter. If you see the left side you can see two ureters. Both of these ureters are having two different openings. This is complete duplication. Complete duplication. So two types, incomplete, complete. If you're going to notice, this upper pole ureter is opening outside the bladder in urethra. On left side, you can see this upper pole ureter. It is draining into the urethra, not into the bladder. So this is having ectopic ureteric orifice. Second thing, if we are going to compare it from lower pole ureter, it is caudal and medial in comparison to lower pole ureter, and this is known as Wiegert-Mayer's rule. So what's the name of this rule? This is Wiegert-Mayer's rule, in which upper pole ureter is distal or caudal and medial in comparison to lower pole ureter. Now look at the problems. This is the lower pole ureter. This is having short intravesical length, so it's having vesico-ureteric reflux. Upper pole ureter, if you see, there is cystic dilatation of terminal part of ureter. So this is having ureterocele problems. Ureterocele. Second problem in upper pole ureter, that it is opening outside bladder, so there is ectopic ureteric orifice. Now see the investigation and management. For VUR, what is the investigation of choice? It is MCU. And what is the treatment? We go for uretrovesicoplasty. Uretrovesicoplasty for lower pole ureter, which is having VUR. If you see this upper pole ureter, which is having ureterocele, investigation of choice for diagnosis IVP, we saw adder head or cobra head appearance. And what is the treatment? Excision with reimplantation into bladder. So the treatment is excision with reimplantation into bladder. This is related to investigation and management. Now another question related to ectopic ureteric orifice. Now see, this is the urethra. This is external urinary sphincter. What is the problem in males? This ectopic ureteric orifice is having opening into anterior urethra. We discussed that upper pole ureter is having ectopic ureteric orifice. Where is the opening? If we see in males, it is in the posterior urethra. And what's the most common site? It's the prostatic urethra in males. And what's the location in females? This opening, it's in anterior urethra in females. Where? It's the anterior urethra. Okay. So see here, this is external urinary sphincter. In males, the opening is proximal to urinary sphincter. That's why males are continent. And in females, it's distal to external urinary sphincter. That's why females are having continuous incontinence. What kind of? Females are having continuous incontinence. Okay, so males are having recurrent UTI, but they are continent. In females, there is continuous dribbling of urine with normal voiding pattern. So this is the characteristic feature of duplication. We discussed vesico-ureteric reflux. It's the most common congenital abnormality of urogenital tract. This is autosomal dominant. It is more common in children. Most of the patients are asymptomatic, and what's the good thing? Spontaneous resolution occurs by 5 to 6 years of age. So spontaneous resolution by 5 to 6 years of age in VUR. What is the investigation of choice for VUR? We discussed it is micturating cystourethrogram, MCU. This micturating cystourethrogram, it's the investigation of choice for three conditions. First, VUR. Second is the posterior urethral valve, and posterior urethral stricture. For all these, investigation of choice for diagnosis is MCU. On the basis of MCU, there is grading of VUR, and this classification is known as International Classification of VUR. This is the international classification of VUR. What happens in grade 1, you can see the reflux into non-dilated ureter. So reflux into non-dilated ureter is grade 1. Reflux into pelvic-calyceal system, it is grade 2. And in grade 3, there is mild to moderate dilatation. So here you can see mild to moderate dilatation with reflux into pelvic-calyceal system. What is the catch point in grade 4? That here there is blunting of fornix. Here you can see the fornix is blunt. So blunting of fornix occurs in grade 4. Apart from reflux into pelvic-calyceal system, there is blunting of fornix. And in grade 5, you can see the ureter is dilated, tortuous. And where is the reflux? Reflux is up to the pelvic-calyceal system. So this is international classification of VUR. In patients of VUR, we have to keep the urine sterile. Why? Because if there is UTI, what will happen? The infection can reach to kidney and it can lead to pyelonephritis. So irrespective of grade, in all patients of VUR, we give prophylactic antibiotics. So what we have to give? Prophylactic antibiotics to prevent pyelonephritis, because pyelonephritis can lead to scarring and permanent changes are there in the kidney after this pyelonephritis. So we give prophylactic antibiotics. In low grade VUR, medical management is sufficient. Surgical management is required, only limited patients. So what are the indications of medical management? Grade 1 to grade 3 VUR, and if patient is having unilateral grade 4 VUR. Okay, so question is simple. What are the indications of surgical management? Okay, so here you can see grade 1 to grade 3 VUR and unilateral grade 4 VUR. It means what? First, bilateral grade 4 VUR. First, second, grade 5 VUR. Grade 5 VUR. If patient is having recurrent UTI despite of antibiotics, so the patient is having recurrent UTI despite of antibiotics. If patient is older, so older children, because chances of spontaneous resolution is maximum till 5 to 6 years of age. Patient is having some complication. What? If there is permanent scar, or patient is having some kind of anatomical abnormality like bladder diverticula. If there is bladder diverticula. So bilateral grade 4 VUR, grade 5 VUR, recurrent UTI despite of antibiotics, older children, presence of permanent scar, and if there is presence of bladder diverticula, these are the indications for surgical management. We discussed what we do for VUR. We perform uretrovesicoplasty. We inject Teflon, that's known as sting operation. So that is subureteric transurethral injection of Teflon. And the third is ureteric implantation. So third treatment option is ureteric implantation. So in ureteric implantation, there are two techniques. One is Litch-Grigor technique, and there is Leadbetter-Politano technique. Leadbetter-Politano. Okay, which one is preferred? It's the Litch-Grigor technique which is preferred. So this is how we manage the patients of VUR. This is all about kidney and ureter. These are the pictures of ectopia vesicae. What is the other name of ectopia vesicae? It is also known as extrophy bladder. So what is the problem in extrophy bladder? There is complete ventral defect of urogenital sinus. What kind of defect? Ventral defect. And because of this ventral defect of urogenital sinus, see what are the findings you can see here. It's a newborn baby. In this newborn baby, you can see umbilical cord. Here, there is absent infraumbilical abdominal wall. Absent infraumbilical abdominal wall. And you can see there is absent anterior wall of bladder. So anterior wall of bladder is also absent, and you can see exposed posterior wall. And here you can see these whitish structures. So this is what? Trigone. So what are the important findings? Absent infraumbilical abdominal wall, absent anterior wall of the bladder, exposed posterior wall, and there is urine dribbling from trigone. See, this is the image of an adult patient. What are the associated findings you can see apart from ectopia vesicae? So here you can see that there is epispadias, you can notice. If you see the scrotum, you can see it's empty. So what? There is undescended testis and shallow scrotum. Shallow scrotum. Right? So in males, what are the associated abnormalities in ectopia vesicae? There is epispadias, there is undescended testis and shallow scrotum. In females, there is epispadias, bifid clitoris and widely separated labia. So these are important points related to ectopia vesicae. What are the types of bladder stone? So bladder stones are of two types. One is primary and one is secondary. Both primary and secondary bladder stones are formed in the bladder. Primary bladder stones are formed in the bladder in absence of anatomical, functional, infectious or obstructive factors, whereas secondary bladder stones are formed in the bladder because of anatomical, functional, infectious or obstructive factors. Clear? So both of these bladder stones are formed in bladder. There is a third term known as migrant bladder stone or migrant bladder calculi. If it is migrant, so generally this stone is formed in the kidney and it is dropped into the bladder via ureter, retained into the bladder because of distal obstruction. So what is migrant bladder calculi? Formed in the kidney, retained in the bladder because of distal obstruction. First we are going to discuss primary bladder stone. What is the other name of primary bladder stone? It's also known as endemic bladder calculi. Primary bladder stone is more common in children and generally in which particular age group? 2 to 4 years. The question which is frequently asked related to primary bladder stone, that what's the most common type of primary bladder stone? This is ammonium urate. You can find calcium oxalate stone also, but the most common type of primary bladder stone, it's ammonium urate. Important question. Most common type of primary bladder stone is ammonium urate. What's the age group? 2 to 4 years. So once we are going to treat primary bladder stones, these stones rarely recur. You have to remember, after treatment, these stones rarely recur. If we compare primary bladder stone and secondary bladder stone, overall, which one is more common? So overall, secondary bladder stone is more common. And you know, this secondary bladder stone is more common in elderly males. Why? Because of distal obstruction. So elderly males are having BPH, benign prostatic hyperplasia, or bladder outlet obstruction. Because of that, it's more common in elderly males. Secondary bladder stones are more common in elderly males. Why? Because of BPH or bladder outlet obstruction. Second important point. What is the most common type of secondary bladder stone? It is uric acid followed by struvite. It's uric acid followed by struvite. You know that this uric acid is radio-opaque or radiolucent stone. So it's radiolucent stone. So majority of bladder stones are secondary. Most common type of secondary bladder stone is uric acid, and uric acid stone is radiolucent. So most of the bladder stones are what? Radiolucent. Nowadays lots of image based questions are asked related to bladder stone. So here you can see there is a radio opaque stone in the bladder in the first picture. If you see the second picture, the shape of this stone, see the shape of stone is something like this. Okay, look at this stone. So this is the stone, shape is something like this. It is looking like a toy and the name of that toy is Jack. Since it looks like a toy, the name of that toy is Jack. So what is the name of this stone? This is the Jack stone. Jack stone. What is the composition of this Jack stone? This is calcium oxalate dihydrate. So Jack stone is calcium oxalate dihydrate and the Jack stone is found in the bladder. Okay. So Jack stone composed of calcium oxalate dihydrate. It is found in the bladder. Now coming to the clinical features, diagnosis and treatment. Irrespective of type of the stone, clinical features, diagnosis and management is same. So it's same in primary as well as in secondary bladder stone. What are the clinical features in the patients who are having bladder stone? So these patients have intermittent painful voiding, pain at the time of micturition. There is severe pain at the end of micturition, and when patient is going to finish the micturition, there is passage of 1 to 2 drops of blood at the end. 1 to 2 drops of blood at the end, and that's known as terminal hematuria. So there is intermittent painful voiding with severe pain at the end of micturition with passage of 1 to 2 drops of blood at the end. That's terminal hematuria. How we are going to make the diagnosis? It's easy. First, what's the investigation of choice? So see, for gallbladder stone and for urinary bladder stone, investigation of choice is same, and that's ultrasound. So here also, what's the investigation of choice for diagnosis? That's ultrasound. See the management. For small stone, we are going for cystolitholapexy. Cystolitholapexy. And what are the treatment options available for large stones? We can break the stones and remove it with the help of electrohydraulic lithotripsy. And the second option is we can go for suprapubic cystolithotomy. Cystolithotomy. So we open the bladder, take out the stone. So this is suprapubic cystolithotomy. Another important topic is schistosomiasis. What is the other name of schistosomiasis? Bilharziasis. What is the organism responsible? So it is the Schistosoma hematobium. Name of organism, Schistosoma hematobium. If you see the host for Schistosoma hematobium, what is the definitive host? Definitive host means host in which sexual phase of cycle is occurring, and that's man. It's the man. And what is the intermediate host? Is the snail. So in this case, intermediate host in which asexual phase of cycle is occurring, and that's what? Snail. There are two important clinical findings associated with schistosomiasis. One is the swimmer's itch and second is Katayama fever. Swimmer's itch means at the site of penetration of cercaria, there is severe itching within 24 hours. So two important findings. First, swimmer's itch. You have to remember the name. Swimmer's itch generally seen within 24 hours of penetration of cercaria, and second is Katayama fever. Katayama fever. We discussed in genitourinary tuberculosis that what is the most common, earliest. So what is the earliest most common symptom of genitourinary tuberculosis? It's increased frequency. Same symptom is seen here also. So in schistosomiasis also, earliest most common symptom is increased frequency. Okay, so two important questions in genitourinary tuberculosis and in schistosomiasis. Schistosomiasis, yes, earliest most common symptom, that's increased frequency. So what's increased frequency? It's the increased frequency of urination or micturition. You know, in schistosomiasis there is chronic inflammation going on, and because of this chronic inflammation there are two problems. One, there is calcification. What's the problem? There is calcification and there is increased risk of malignancy. Which one? Squamous cell carcinoma followed by transitional cell carcinoma. So if you see the question, most common cause of bladder calcification worldwide, and what's the cause? Schistosomiasis. Schistosomiasis is the most common cause of bladder calcification worldwide. Schistosomiasis increases the risk of both squamous cell carcinoma as well as transitional cell carcinoma, but risk is more for squamous cell carcinoma. Diagnosis of schistosomiasis is very easy. If we are going to examine the urine, you are going to find the presence of eggs. So how you can make the diagnosis? On urine examination, there is presence of eggs. Presence of eggs. We discussed that it leads to bladder calcification. So if you go for the X-ray, what kind of appearance is there? In this picture, you can see what? That there is fetal head in pelvis. Yes. So because of bladder calcification, what is the name of this appearance? This is fetal head in pelvis appearance. So important finding, on X-ray there is fetal head in pelvis appearance. Fetal head in pelvis. Okay. For schistosomiasis, what's the drug of choice? You must be knowing. It's praziquantel. So drug of choice for schistosomiasis, that's praziquantel. Okay. So what's the drug of choice for schistosomiasis? It's the praziquantel. In this cystoscopy, you can see presence of linear bleeding ulcer in the fundus. So in the fundus of bladder, there is presence of linear bleeding ulcer, and this is known as Hunner's ulcer. What is the other name of Hunner's ulcer? It's also known as interstitial cystitis. Hunner's ulcer, also known as interstitial cystitis. So in this, what happens? There is chronic pancystitis and etiology is not known. Whenever we are going to perform the cystoscopy, we are going to find presence of linear bleeding ulcer. Where exactly? In the fundus. What are the types of bladder rupture? It is of two types. One is extraperitoneal and the second is intraperitoneal. Which one is more common? Extraperitoneal bladder rupture is responsible for 80% cases. Intraperitoneal bladder rupture is responsible for 20% cases. Now see the location of bladder. In the collapsed state, bladder is located in the pelvis, and when bladder becomes distended, it becomes intra-abdominal. So whenever bladder is collapsed, road traffic accident is there is pelvic fracture, and because of this fractured segment, what happens? There is extraperitoneal bladder rupture. When bladder is distended and then external blow or kick to suprapubic region can lead to intraperitoneal bladder rupture. So one by one we are going to discuss. So what's the problem? In extraperitoneal bladder rupture, there is road traffic accident. Because of this road traffic accident, there is pelvic fracture, and because of this pelvic fracture, since bladder in collapsed state is located in the pelvis, there is extraperitoneal bladder rupture. And you know, some part of urethra is also located in pelvis. Which one? Posterior or anterior part? Posterior part. So it leads to posterior urethral injury also. There is posterior urethral injury. So what's the most common cause of posterior urethral injury? Pelvic fracture because of road traffic accident. Most common cause of extraperitoneal bladder rupture? Pelvic fracture because of road traffic accident. So you know, both of these are associated. Extraperitoneal bladder rupture is associated with posterior urethral injury. See the location of bladder. So what will be the clinical features in rupture? These patients have suprapubic pain. There is difficulty in making the pressure in the bladder. So what's the problem? There is difficulty in passing urine, and whenever urine is coming, it is mixed with blood. So hematuria. So clinical features: suprapubic pain, difficulty in passing urine, and hematuria. How we are going to make the diagnosis? Investigation of choice for diagnosis is CT cystography. So diagnosis, investigation of choice for diagnosis is CT cystography. There are various signs seen on CT cystography. What are the names of sign? Have a look. On the CT cystography, see the pattern of contrast extravasation. It looks like flame. That's why what's the name of this sign? This is flame sign. It is flame sign. If you see the second image here, it is looking like pear. So this is pear shaped bladder or pear sign. Pear sign. And if you see this image here, the appearance is like teardrop. So this is teardrop bladder. It's the teardrop bladder. So three important signs seen on CT cystography: flame sign, second is pear shaped bladder or pear sign, and third is teardrop bladder. In extraperitoneal bladder rupture, there is tear caused by the fracture segment. So what is required? We go for Foley's catheterization. Foley's catheterization. So in majority of cases, Foley's catheterization is sufficient and spontaneous healing occurs within 7 to 10 days. So what is the cause of intraperitoneal bladder rupture? In the distended or full bladder, external blow or kick. And whenever there is intraperitoneal bladder rupture, what will happen? Whatever the urine is there in the bladder, that urine will go into the peritoneal cavity. So apart from suprapubic pain, difficulty in passing urine, hematuria, there is one additional symptom, and what's that? Peritonitis. So in these patients, the additional symptom is what? Peritonitis. Here also, investigation of choice for diagnosis is same, and that is CT cystography. See this CT cystography, here you can see the extravasation of contrast into the peritoneal cavity, and this is having sunburst appearance. So on CT cystography, what is the sign seen? On CT cystography, there is sunburst appearance because of extravasation of contrast. Here, the treatment is different because there is peritonitis. So, we perform exploratory laparotomy, we perform peritoneal lavage. There is bladder defect, so we repair the defect, insert the Foley's, or we insert the suprapubic catheter. So, how we management? Perform exploratory laparotomy. We perform peritoneal lavage because there is extravasation of urine, plus repair of defect, bladder defect, plus suprapubic catheter insertion or Foley's catheterization. Foley's catheterization for intraperitoneal bladder rupture. What is the most common histological type of carcinoma bladder? And you know, the epithelium of bladder is transitional cell epithelium. So most common is transitional cell carcinoma, followed by squamous cell carcinoma, followed by adenocarcinoma. Adenocarcinoma. Important question. These three are having different risk factors which are very important. Have a look. So see the risk factors of transitional carcinoma first. One of the most important risk factor for transitional cell carcinoma is smoking. There are certain drugs which are going to increase the risk. One is phenacetin and the second is chlornafazine. Chemotherapy agent, you must be knowing cyclophosphamide, which increases the risk of hemorrhagic cystitis. That agent also increase the risk of transitional cell carcinoma. Exposure to aniline dyes, especially in printing industry, in dyeing industry, increases the risk. We discussed schistosomiasis increases the risk of both transitional cell carcinoma as well as squamous cell carcinoma, but the risk is more for squamous cell carcinoma. If patient received pelvic radiotherapy or pelvic irradiation, that's also a risk factor for transitional cell carcinoma. The risk factor of squamous cell carcinoma is mainly related to chronic inflammation. And you know, in schistosomiasis, there is chronic inflammation. Because of bladder stone, because of bladder diverticula, because of prolonged catheterization, what happens? There is chronic inflammation. So these are the risk factors for squamous cell carcinoma. We discussed extrophy bladder, also known as ectopia vesica, in the beginning of this chapter. It's a congenital malformation which increases the risk of adenocarcinoma. Patent urachus increases the risk of adenocarcinoma. Whenever we are making intestinal conduit for the bladder, or sometimes we are going for augmentation enterocystoplasty, where we use intestinal mucosa, all these are the risk factor for what? Adenocarcinoma. Now see, what is the difference between transitional cell carcinoma, squamous cell and adeno? Out of these three malignancies, only transitional cell carcinoma responds to intravesical BCG. It means in early stages of transitional cell carcinoma, we can save the bladder, but we cannot save the bladder in squamous cell carcinoma and adenocarcinoma. So if a patient is having squamous cell carcinoma, which is nodular and invasive, what's the treatment? We go for radical cystectomy. And if a patient is having adenocarcinoma, you know, in adenocarcinoma there is lymphatic spread. In CA bladder there is involvement of pelvic lymph node. Which one? Obturator. So here we go for radical cystectomy. Apart from radical cystectomy, what else we perform? Since there is involvement of pelvic lymph node, so we perform pelvic lymphadenectomy. So treatment: squamous cell carcinoma, radical cystectomy. Adenocarcinoma, radical cystectomy plus pelvic lymphadenectomy. Transitional cell carcinoma is the most common type. We are going to discuss in detail. We discussed what is the most common histological type. It's the transitional cell carcinoma. And carcinoma bladder, it is more common in males, smokers, and in which particular age group? 60 to 70. Male smokers 60 to 70. One thing we have to remember, that what is the most common site? of transitional cell carcinoma or carcinoma bladder. So it is actually posterolateral wall of trigone. You have to remember, posterolateral wall of trigone is the most common site. So the most common site is posterolateral wall of trigone. What is the most common symptom of carcinoma bladder? That's hematuria. What kind of? It is painless, it is gross and intermittent. This is the mistake you do in exam. It's not continuous hematuria. There is intermittent hematuria. So painless, gross, intermittent hematuria is seen in CA bladder. Now see the important points related to route of spread. What is the most common route of spread? It is hematogenous. And here most common site of metastasis is not the lungs, it's liver. In majority of urogenital malignancies like RCC, testicular tumor, carcinoma penis, most common site of metastasis is lungs. In CA bladder, it is liver. It is liver. We discussed that there is involvement of pelvic lymph nodes and which particular group? Obturator. So most commonly involved group of lymph nodes, obturator among the pelvic lymph nodes. How we make the diagnosis? So obviously we go for cystoscopy and we take the biopsy. So investigation of choice for diagnosis, that is cystoscopy. We go for cystoscopy and we take the biopsy. Simple. How we stage the malignancy? We discussed that for head and neck malignancies and for pelvic malignancies where there is overcrowding of soft tissues like nerves, vessels, muscles, in all these cases, investigation of choice for staging is MRI. So you know, investigation of choice for staging of head and neck malignancies as well as pelvic malignancies. Yes, that is MRI. The management of CA bladder is dependent on the stage. If a patient is having TIS, that is also known as carcinoma in situ, TIS, carcinoma in situ, also known as malignant cystitis. In this case, what is sufficient? Intravesical BCG. If patient is having TA, that is papillary tumor. If it is single, low to moderate grade, non-recurrent, what is sufficient here? We go for transurethral resection. So we go for transurethral resection of bladder tumor. But imagine the situation if there is papillary tumor which is multiple, high grade and recurrent. In these cases, apart from transurethral resection, we have to give intravesical chemotherapy. Intravesical chemotherapy. Not only for TA, for T1 also, we go for transurethral resection of bladder tumor plus intravesical chemotherapy. If the patient is having advanced malignancies like T2 to T4, here the main treatment is we go for radical cystectomy. This is the main treatment, right? In certain cases, advanced malignancy is there, so we can downstage it by chemotherapy. So either we go for neoadjuvant chemotherapy followed by radical cystectomy. This is one option. In certain patients, after radical cystectomy, we are going to notice that margins are positive. In that case, you can go for radical cystectomy followed by adjuvant chemotherapy plus minus radiotherapy. So these are the options for T2 to T4. Imagine a situation that if patient is having N plus or M plus tumor. N plus or M plus tumor means if there is lymph node metastasis or distant metastasis. So in cases of metastasis, what is the preferred treatment option? We go for neoadjuvant chemotherapy followed by surgery or palliation depending upon the presentation and condition of tumor. So for metastatic tumors, preferred treatment is neoadjuvant chemotherapy followed by surgery or palliation. Here, the neoadjuvant chemotherapy or these kind of chemotherapy, it means it's the systemic chemotherapy. It is not intravesical chemotherapy. So what's the systemic chemotherapy which is given in CA bladder? The name of the regimen, it is MVAC. This was asked in NEET PG. MVAC for CA bladder. Full form, M means methotrexate, V means vincristine, A means adriamycin, and C is cisplatin. Cyclophosphamide is not there, it's cisplatin. Why not cyclophosphamide? Because cyclophosphamide increases the risk of carcinoma bladder. So this is the chemotherapy regimen. What are the intravesical chemotherapy agents which are given in CA bladder? How to remember intravesical chemotherapy agents? Intravesical chemotherapy MET BCG. Mnemonic is intravesical chemotherapy MET BCG. So it is mitomycin C, epirubicin, thiotepa, and BCG. Out of these four, which one is most effective? It is BCG is most effective. So BCG is most effective intravesical chemotherapy agent. So this is all about urinary bladder. Now we are going to discuss the prostate and seminal vesicle. So let's discuss the anatomy first. So previously we were following the lobes of prostate. So how many lobes are there in the prostate? In the prostate there are total 5 lobes. What are the 5 lobes? Anterior, posterior, 2 lateral lobes, and there is median lobe. Okay, so there are total 5 lobes: anterior, posterior, 2 lateral lobes, and 1 median lobes. But nowadays we follow McNeil zones. What we follow? McNeil zones. And according to McNeil zones, how many zones are there? There are 4 zones. So what are those 4 zones? Here you can see there is transition zone. Here you can see there is central zone. This is peripheral zone. And fourth is anterior fibromuscular stroma, that is also known as anterior fibromuscular zone. Now it's very easy to understand. Here you can see this is urethra. Okay, this is urethra. So in relation to urethra, you can notice that which zone is around urethra. 2/3 of urethra is covered by transition zone. It means BPH is most common in which zone? BPH is most common in transition zone. Okay, and which lobe? Median lobe. So what are the important questions which are asked? We are going to discuss one by one. First, BPH. BPH is common in which lobe? It is median lobe. And which zone? Transition zone. If the question is asked carcinoma prostate, it's most common in which lobe? Yes, it's most common in posterior lobe. And which zone? This is the peripheral zone. Simple. Whenever we are performing the digital rectal examination, on digital rectal examination, which zone is being palpated? Peripheral zone. Which lobe is mainly palpated on digital rectal examination? Peripheral lobe. Median lobe is usually not palpable. It is palpable when it's enlarged. So I'm repeating. On digital rectal examination, we palpate the posterior lobe. Median lobe is palpable when it is enlarged. Another important point, see, there is no direct correlation between size of prostate and severity of symptoms. Why? Have a look. Imagine if a nodule is located in the peripheral zone. Since it is far away from urethra, what is the problem? If it's there, then also patient is not having any symptom. And if a smaller nodule is there, which is closer to urethra, patient will be having symptoms. That's why there is no direct correlation between size of prostate and severity of symptoms. And that's why you notice that since carcinoma prostate is most common in peripheral zone, most patients are asymptomatic initially. Why most patients of carcinoma prostate are asymptomatic initially? Because the location is in the peripheral zone. Right? So these are the important questions related to anatomy. Now we are going to discuss benign prostatic hyperplasia, that's BPH. And you know, it is age-related, endocrine controlled, multifactorial process. It is endocrine controlled, so it's under control of which hormone? Testosterone. It's under the control of testosterone. It's very easy to understand the pathophysiology, and if you understand the pathophysiology, treatment becomes easier. Have a look at pathophysiology. So whenever we are going to cut any nodule, what are the 2 components? There is epithelium. After cut section, 2 components, epithelium and stroma. In the stroma, there is collagen and smooth muscle. Simple. Smooth muscle. you know that testosterone is not active substance. It is converted into 5-dihydrotestosterone with the help of 5-alpha reductase. So here, this is the testosterone, okay? It is converted into 5-dihydrotestosterone with the help of its enzyme. It's the 5-alpha reductase. Simple. And you know, this 5-dihydrotestosterone, it is having positive effect on epithelium. Simple. Now imagine a patient who is having BPH having major component in the form of epithelium. We can give 5-alpha reductase inhibitors. So for such patients we give what? 5-alpha reductase inhibitors. And if in a patient smooth muscle component is predominant, here we give alpha blockers, and you know alpha blockers leads to instant smooth muscle relaxation. Simple. Instant smooth muscle relaxation. So we can use both 5-alpha reductase inhibitors or alpha blockers. What's the problem with 5-alpha reductase inhibitors? 5-alpha reductase inhibitors minimum require 1 month to act. So they require minimum 1 month to act, and the maximum effect is seen in 6 months in 5-alpha reductase inhibitors. Advantage of alpha blockers that these are instantaneously active. Instantaneously active. So which one is preferred in the management of BPH? Obviously alpha blockers. Because of presence of nodule in transition zone, what happens? There is obstruction of urethra, and because of obstruction of urethra there is obstructive symptoms like there is poor flow, poor stream, there is hesitancy, intermittency, the flow is not continuous, there is dribbling of urine, and even after micturition or urination patient is having this kind of feeling of residual volume in the bladder. It means that's incomplete evacuation. There is a second symptom seen, irritative symptoms, and these irritative symptoms are because of secondary changes in the bladder. So how to remember? The mnemonic is FUN, and it consists of frequency, urgency, nocturia. So these are the symptoms. When these patients are coming to our OPD, we perform digital rectal examination, and on digital rectal examination in cases of BPH there is smooth elastic enlargement of prostate. What's the problem in carcinoma prostate? In carcinoma prostate, obviously the prostate is enlarged, it's hard, and there is median sulcus obliteration. Prostate is enlarged, hard, and there is median sulcus obliteration. So what are the investigations which are performed? We perform uroflowmetry. So we measure the urine flow, that is measured by Qmax. So maximum flow rate. In normal patients, the maximum flow rate is more than 15 ml per second. If it is 10 to 15 ml per second, it means it is equivocal. It is equivocal. And if it is less than 10 ml per second, it is suggestive of BPH. Why suggestive of BPH? Because the patients who are having neurogenic bladder, they cannot generate enough force, and in those cases also the Qmax is less than 10 ml per second. So this value is not diagnostic. If we want to differentiate the neurogenic bladder from BPH, we have to perform the cystometry. So on cystometry, if the voiding pressure is more than 80 centimeter of H2O, this is diagnostic. So what is the diagnostic criteria of BPH? First, the Qmax less than 10 ml per second, and cystometry, the voiding pressure more than 80 centimeter of H2O. When the diagnosis is confirmed, we have to start the treatment. And you know, in patients of BPH, we prefer the medical management, and majority of patients improve after medical management. We discussed that we use alpha blockers and 5-alpha reductase inhibitors. Why alpha blockers are preferred? Because these are instantaneously active. What are the alpha blockers which are used? Prazosin, terazosin, doxazosin. It's a new drug. It's a new drug. And what's the name of this drug? Silodosin. It was asked in DNB. New drug used for BPH. Most commonly used is tamsulosin, is alpha 1A selective blocker. So this is preferred, and it comes in the market by the name of Urimax. Okay. Second option, we can use 5-alpha reductase inhibitors, but we discussed minimum time required to act 1 month. Maximum effect is seen in 6 months. What are the drugs used? It is finasteride, dutasteride, triptorelin palmoid. Certain patients who have large prostate. One problem, patients who are having large prostate, and the patients who are having high PSA. In the patients with large prostate and raised PSA, what We give combination treatment. So we give combination of both alpha blockers plus 5 alpha reductase inhibitors. This question is asked. Combination treatment is given in the patients having large prostate and raised PSA. Most patients improve after medical management, but there are certain indications for surgical intervention, like if there is no improvement after medical management, patient is getting the treatment, but what patient is having recurrent urinary tract infection. If patient developed hydronephrosis or there is evidence of renal failure because of obstruction, there is formation of secondary bladder stone. So if patient is having bladder stone, if there is gross hematuria, or patient is having refractory urinary retention, all these are the indications for surgical treatment. And what's the gold standard treatment for BPH? It's TURP, that is transurethral resection of prostate. See the important points related to TURP. First, what is the most preferred technique? It's the Nesbitt technique. Name of technique? It is the Nesbitt technique. What we do in this case, there is dithermy loop or wire loop in resectoscope. With the help of this wire loop, can you see, we are going to remove the chips of tissues. So chips of tissues are being removed. Whenever we are performing TURP, there is bleeding also. So for irrigation, we use some fluid. And what is the preferred fluid for irrigation? You have to remember the percentage and the name. 1.5% glycine. Generally, we use monopolar cautery. With monopolar cautery, electrolyte solution like normal saline should not be used. Okay, so with monopolar cautery, we are using 1.5% glycine. But we can use normal saline with bipolar cautery. And if you use normal saline with bipolar cautery, this is known as TURIS. What is the full form? It is TURP in saline, TURIS. You know that there is one landmark in TURP, and beyond this landmark, we are not going to perform the resection. And this landmark is what? Verumontanum. Verumontanum. So Verumontanum is most important distal landmark for TURP. Why? Because this Verumontanum is located just proximal to external urinary sphincter. I'm repeating. Verumontanum is most important distal landmark for TURP. Why? Because it is located just proximal to external urinary sphincter. What are the complications of TURP? The most common complication of TURP is retrograde ejaculation, seen in 75% of patients. Impotence, it is seen in 10% of patients, and incontinence seen in less than 1%. So most common complication is what? Retrograde ejaculation. There is twist in the question sometimes. They ask most common late complication of TURP. So if the question is most common late complication, then it is bladder neck stenosis followed by urethral stricture. So most common late complication, bladder neck stenosis followed by urethral stricture. This was asked in All India. So it's bladder neck stenosis followed by urethral stricture. Urethral stricture. Okay. Certain patients are coming to you saying that, sir, I don't want these complications. Which one? Retrograde ejaculation, impotence, incontinence, and my prostate is smaller also. What's the size? It's up to 20 grams. So I don't want these complications. I want some other surgery. So in these patients, we go for TUIP. So what's that TUIP? It is also known as transurethral incision of prostate. So we perform the incision. And how many incisions? We perform 2 incisions, one at 5 o'clock and one at 7 o'clock. With which knife? Collins knife. This is performed for smaller prostate. You have to remember the size, up to 20 grams. For the prostate size, up to 20 grams. There is one more problem with TURP, that whenever we are going to perform TURP for the duration more than 90 minutes, there is water intoxication, also known as dilutional hyponatremia, also known as TUR syndrome. So what is this TUR syndrome, water intoxication or dilutional hyponatremia? Whenever the size of prostate is more than 75 grams and whenever duration of TURP is more than 90 minutes. Size more than 75 grams, duration more than 90 minutes, there is increased absorption of irrigant or the fluid used for irrigation, and because of that what happens, there is volume overload, and because of that it's not true hyponatremia, it's dilutional hyponatremia, also known as water intoxication. So this patient is going to develop signs and symptoms of what? Hyponatremia, and signs and symptoms of what? Volume overload. Because of hyponatremia, you are going to notice that these patients are going to develop dizziness, there is confusion, visual abnormalities. These patients are going to develop bradycardia. There is hyponatremia, volume overload, so there is bradycardia and there is hypertension. Treatment is very easy. Since there is fluid overload or volume overload, what's the drug of choice? Obviously, it's the furosemide. Drug of choice is furosemide. You give furosemide. What happens even after furosemide, patient is still symptomatic. So if there is no improvement, it means still this hyponatremia is not corrected. And even after furosemide, if patient is not improving, we give hypertonic saline. So what we give? 3% saline, that is hypertonic saline. How much? 3% saline. Clear? This is how we manage the patients of TUR syndrome. There is a third group of patient in whom the size of prostate is larger, more than 75 grams, or already there is presence of bladder pathology like bladder stone or bladder diverticula. In these cases, we prefer open prostatectomy, right? Because if the size is more than 75 grams, you go for TURP, there is TUR syndrome. And in open prostatectomy, when we are performing prostatectomy, we can treat the bladder pathology also. What are the treatment options? So the named prostatectomies are Freyer's suprapubic prostatectomy, Millin's retropubic prostatectomy, and Young's perineal prostatectomy. Out of these three, this one is obsolete, not done nowadays. So how to remember? Young is very old. So Young's perineal prostatectomy, it's not done nowadays. Another important question, that if patient is having bladder stone or bladder pathology like bladder diverticulum, which one is preferred? Freyer's suprapubic prostatectomy or Millin's retropubic prostatectomy? And obviously we prefer what? Freyer's suprapubic prostatectomy for bladder pathologies. Nowadays we use laser also. Which one? Hoyag laser. So it is holmium Yag laser, and this holmium Yag laser is used for renal stones and it is used for BPH. Important question. Holmium Yag laser is used for the treatment of renal stones and BPH, benign prostatic hyperplasia. There are three conditions in which the organism is same. Most common organism responsible for these three conditions: acute bacterial prostatitis, chronic bacterial prostatitis, and prostatic abscess. And what's the most common organism responsible? This is E. coli. Another important question which is asked, that's prostatic calculi. It is calcified Carpora amylacea. So what is the composition? Calcium phosphate. See the location of these stones. These stones are located at the periphery of transition zone. Where? At the periphery of transition zone. So if you see the location, tell me, these patients are symptomatic or asymptomatics? Because of this location in the periphery of transition zone, majority of patients are asymptomatic. Okay, so the questions which are asked, that prostatic stone or calculi is calcified Carpora amylacea, and what's the composition? Is the calcium phosphate. Now we are going to discuss carcinoma prostate. Prostate is a gland, so malignancy arising from gland is generally adenocarcinoma. So what is the most common type? Adenocarcinoma. Okay, followed by transitional cell carcinoma. Adenocarcinoma followed by transitional cell carcinoma. We discussed adenocarcinoma is more common in high socioeconomic status, so this is more common in high socioeconomic status. It is seen in old age, especially 7th to 8th decade. Okay, so what are the risk factors? Since it is more common in high socioeconomic status, one, high fat diet, and the second is advancing age. Risk factors: high fat diet and advancing age. What is the most common site of carcinoma prostate? It's the peripheral zone. So since the location is in the peripheral zone, these patients are symptomatic or asymptomatic. Majority of patients are asymptomatic in initial stages. Patient is asymptomatic. What is the most common site of metastasis? It's the lumbar vertebra. So whenever there is metastasis to lumbar vertebra, because of metastasis, these patients are going to ortho department because of backache. And when we are performing the investigations, we are going to find that there are metastatic lesions in the vertebra. Okay, what kind of secondaries are seen? Most common site is lumbar vertebra, lumbar vertebra. And what kind of secondaries? There are osteoblastic secondaries. We discussed most common primary responsible for osteoblastic secondaries in males, CA prostate. Most common primary responsible for osteolytic secondaries in males, RCC. And most common primary responsible for both osteoblastic and osteolytic secondaries in females, CA breast. Okay. Adenocarcinoma, this is adenocarcinoma, so there is lymphatic spread also. Which group of lymph nodes are involved? Since prostate is in the pelvis, pelvic lymph node, and in pelvic lymph node, which group? Obturator. So there is lymphatic spread also, involvement of pelvic lymph nodes, and which group most commonly? It's the obturator. When we perform the digital rectal examination, we discussed that prostate is enlarged, it is hard, and there is median sulcus obliteration. How we are going to make the diagnosis? So what's the investigation of choice for diagnosis? It's the TRUS guided biopsy, full form transrectal ultrasound guided biopsy. It is TRUS guided biopsy. And prostate is located in pelvis. We discussed for pelvic malignancies, what is the investigation of choice for staging? It's MRI. MRI is the investigation of choice for staging. There is one important tumor marker, that's prostate specific antigen. So first question, prostate specific antigen is prostate specific, not the cancer specific. It means it is raised both in benign conditions as well as in malignancy. What's the normal value? Generally, it's less than 4 nanogram per ml. Which value is diagnostic of carcinoma prostate? Value diagnostic is the more than 20 nanogram per ml. Better than PSA is PSA velocity. And what's this PSA velocity? It's the rate of change of PSA over a period of time. Which value is diagnostic of carcinoma prostate? You have to remember more than 0.75 nanogram per ml per year. Three values you have to remember. PSA value normally less than 4 nanogram per ml. Diagnostic of carcinoma prostate more than 20 nanogram per ml. And PSA velocity diagnostic of carcinoma prostate more than 0.75 nanogram per ml per year. You know that there is Gleason grading which is used for carcinoma prostate. See the management. If patient is having stage T1A, in T1A, it will take at least 10 years to become fulminant. So what is done here? Only observation plus follow-up. And how we do this? DRE plus PSA. So observation plus follow-up, we perform digital rectal examination and we go for PSA. If patient is having T1B, T1C or T2, in these stages, we have to see what's the age of patient. If the age of patient is more than 70 years, in such cases, no need to do any active intervention, observation and follow-up. If patient age is less than 70 years, in these patients, we go for what? Radical prostatectomy. In these cases, we go for radical prostatectomy. So you have to remember the age also. Certain patients at this particular age, they have contraindication for surgery. So if surgery is contraindicated, we have another option. What? Radiotherapy. Remember, radical prostatectomy is preferred over radiotherapy. Third situation, if the patient is having advanced malignancy like T3 and T4, we discussed that prostate there is positive effect of testosterone. So in such patients we go for androgen ablation, and this androgen ablation is preferred over palliative radiotherapy. So for these patients, what is preferred is the androgen ablation, and this androgen ablation, it is preferred over palliative radiotherapy. What are the options available? Either you cut the source of production of testosterone surgically or medically. So we can go for bilateral orchidectomy plus flutamide, or we can go for LHRH agonist plus flutamide. So options: bilateral orchidectomy plus flutamide, or we can go for LHRH agonist, plus flutamide. Now comes the question which was asked 5 to 6 times in AIIMS, that which LHRH agonist? We give goserelin and leuprolide. And what is the famous question which is asked in AIIMS frequently? Yes, recently FDA approved drug for advanced and metastatic carcinoma prostate, and that is goserelin. Question: recently FDA approved drug for advanced and metastatic carcinoma prostate is the goserelin. And in the latest exam there was a new question related to castration resistant, means which is not responding to hormone therapy or androgen ablation. Castration resistant metastatic carcinoma prostate, what are the new drugs used? One is cabazitaxel and second is sipuleucel T. Cabazitaxel, sipuleucel T, this was the question. Sipuleucel T is a vaccine for carcinoma prostate which is castration resistant and metastatic. So this is all about prostate and seminal vesicle. Now we are going to discuss penis and urethra. So first let's discuss the anatomy. What's the length of male urethra? In males the length of urethra is 20 centimeter. And what's the length in females? In females the length of urethra is 4 centimeter. Urethra is further divided into anterior urethra and posterior urethra. What are the components of posterior urethra? There is prostatic and membranous urethra. And what are the parts of this anterior urethra? There is bulbar and penile urethra. Okay. Now see the important questions. Prostatic urethra, it is the widest and most dilatable part of urethra. This one is, it's the widest and most dilatable. That is prostatic. See, membranous is shortest, narrowest and least dilatable. So this one is shortest, narrowest and least dilatable. So this is shortest, narrowest and least dilatable, membranous. Now imagine a question is there, which part of urethra is narrowest? And membranous, meatus, both are there in the options. So if meatus is mentioned in the option, you have to mark meatus. If meatus is not mentioned, then you have to mark membranous. So meatus is overall narrowest part of urethra. And which is longest part of urethra? It's penile. Penile urethra is the longest part of urethra. What are the congenital abnormalities of urethra? Here you can see it's normal because meatus is going to open at the tip of glans penis. If meatus opens over the ventral aspect, meatus is going to open over the ventral aspect of penis. This is hypospadias. And if it is going to open over this dorsal aspect of the penis, that is epispadias. Epispadias is rare, but hypospadias is the most common congenital anomaly of urethra. We are going to discuss in detail. So we are going to discuss hypospadias, which is the most common congenital anomaly of urethra. First question, what is the incidence of hypospadias? It is 1 in 250 live births. What's the incidence of horseshoe kidney? 1 in 400. And what's the incidence of unilateral renal agenesis? This is 1 in 1000. These are the 3 incidences which are frequently asked. So hypospadias 1 in 250, horseshoe kidney 1 in 400, and unilateral renal agenesis 1 in 1000. You know, in hypospadias, these anterior types are more common, responsible for 70% of cases. Anterior types, and overall, if we see, the most common type is this glandular. Glandular type is overall most common. Anterior type is more common than posterior. What are the associations with hypospadias? You can see this is hooded prepuce, and this hooded prepuce is present over which aspect? It is present over dorsal aspect. So there is hooded prepuce present dorsally. There is ventral chordae. Flattened glans penis. If you see the shape, yes, it is flattened. So there is flattened glans penis. Can you notice the meatus? Here is the meatus. So since the location is abnormal, this is ectopic meatus. And if you check meatus, there is meatal stenosis. So there is ectopic meatus, meatal stenosis. The part of urethra which is not going to develop, that part is going to develop fibrosis. So because of fibrosis, if you see the length of penis, it is relatively shorter. That's known as microphallus. So here you can notice that there is hooded prepuce dorsally, there is ventral chordae, flattened glans penis, short length of penis, that is microphallus, ectopic meatus, and what? Meatal stenosis. These are the associations. See, this prepuce is used for reconstruction of urethra. That's why what is contraindicated in hypospadias? Circumcision. So circumcision is contraindicated in hypospadias. Why? Because the prepuce is used for urethral reconstruction. Another important question, what is the best age for repair? And the best age for repair is 6 to 12 months. It is the 6 to 12 months. What we do in repair, first we have to advance the meatus over the tip of glans penis. This is known as meatal advancement. Second, we have to reshape the glans penis, that is known as granuloplasty, and sometimes both of these are performed together. So the name of surgery is MAGPIE. What we perform in hypospadias, we perform MAGPIE, that is meatal advancement, granuloplasty integrated. When we perform the surgery, there is a complication known as urethral fistula. So what's the most common complication of hypospadia surgery? That's urethral fistula. And how much is the incidence? 10%. So most common complication of hypospadia surgery or reconstruction is urethral fistula. Now we are going to discuss posterior urethral valve. In posterior urethral valve, there is presence of valvulae in the posterior urethra. These are symmetric fold of urothelium. What is the extent? It is extending from prostatic urethra till external urinary sphincter. Extent from prostatic urethra till external urinary sphincter, and you know it's exclusively an abnormality of male urethra. Exclusively an abnormality of male urethra. What is the most common type? It's type 1, and this type 1 is located just distal or at verumontanum. Just distal or at verumontanum. Imagine if there is a valve, because of that valve there is obstruction. So what happens? There is vesico-ureteric reflux. So more than 50% patients have VUR. In this case, more than 50% patients have vesico-ureteric reflux. What are the other associations of posterior urethral valve? So you'll find there is oligohydramnios, pulmonary hypoplasia, renal parenchymal dysplasia, and bladder dysfunction. Out of these four, which one is the most common cause of death? The most common cause of death is pulmonary hypoplasia. We discussed congenital diaphragmatic hernia, Bok-Dalek hernia. In that case also most common cause of death was pulmonary hypoplasia, and in posterior urethral valve also most common cause of death is pulmonary hypoplasia. So what's the problem here? There is posterior urethral valve. Because of that there is obstruction, and that's why these patients are having first bilateral hydroureteronephrosis. There is bilateral hydroureteronephrosis. Second thing, if it is bilateral hydroureteronephrosis, that's why after birth there is bilateral palpable abdominal mass. So what's the problem there? There is bilateral palpable abdominal mass because of what? bilateral hydroureteronephrosis. Second thing, here the bladder will be distended because of obstruction. So there is distended bladder, and most of these patients are symptomatic after birth. Why? Because the condition is bilateral. These patients have ascites. What kind of ascites? There is collection of urine. So this is urinary ascites. What kind of ascites? There is urinary ascites. We discussed what is the investigation of choice for diagnosis of posterior urethral valve and the investigation of choice for diagnosis, that is micturating cystourethrogram. It's MCU. And if you perform prenatal ultrasound, what happens? This kind of appearance is there. So this is known as what? Keyhole sign. So on ultrasound, you will find which sign? Keyhole sign in posterior urethral valve. What you can notice in these two pictures, that there is contracted foreskin or contracted prepuce, and this contracted foreskin or prepuce cannot be retracted over glans penis. So this is what? Phimosis. Okay, what's the most common cause of phimosis? Is the chronic infection because of poor hygiene. Lots of people are not going to clean this area. So because of poor hygiene, there is chronic infection, and this is the most common cause. The most common symptom of phimosis is difficulty in micturition. Okay, mother is going to bring the baby saying that, sir, when the child is passing urine, there is ballooning of prepuce. So what's the problem in children? Ballooning of prepuce. And in adults, there is difficulty in intercourse. In adults, there is difficulty in intercourse. What are the complications of phimosis? You can see the patient is not able to clean this area, so there is increased risk of infection of glands as well as prepuce, known as balanoposthitis. The secretion is collected and solidified, leading to formation of stone beneath prepuce known as preputial calculi. And you know, because of chronic inflammation, there is increased risk of carcinoma penis. So what are the management options? In children, we go for steroidal cream application for 4 to 6 weeks. So in children, what? Steroidal cream application. Okay, and for how long? For 4 to 6 weeks. So what are the indications of circumcision? If there is no improvement after steroidal cream application. Second, if the patient is having recurrent infections. And third, if the age of patient is 16 to 18 years. So the question is asked that in children, circumcision is preferred or conservative management. So steroidal cream application is the part of conservative management. And if these options are mentioned in question, then only we go for circumcision. Now see, this is a case of paraphimosis. So what happens in paraphimosis? The prepuce once retracted cannot be brought back to its normal position. This is paraphimosis. It means paraphimosis is only acquired. It's only acquired. Phimosis can be congenital or acquired. So once retracted, there is formation of a tight ring around glans penis. There is edema, and because of that, it cannot be brought back. So phimosis can be both congenital or acquired. Paraphimosis is only acquired. Now we are going to discuss urethral injuries. It is of two types: posterior urethral injuries and anterior urethral injury. Which one is more common? Posterior urethral injury is more common. What happens in this posterior urethral injury? What's the location of posterior urethra? It is located in the pelvis. So what's the most common cause here? There is road traffic accident. Because of this road traffic accident, there is pelvic fracture. And because of this pelvic fracture, there is a bladder rupture. Type of bladder rupture, which one? Extraperitoneal bladder rupture. And there is posterior urethral injury. So extraperitoneal bladder rupture is there, and there is posterior urethral injury. It means you know that both of these are associated. First important question related to posterior urethral injury, that it is associated with extraperitoneal bladder rupture. Second, what is the most common site of injury? It's the membranous urethra. It's the membranous urethra. In the membranous urethra, which junction? Prostatomembranous or bulbomembranous? So here, most common site is bulbomembranous junction followed by prostatomembranous. You have to remember, it's the bulbomembranous junction followed by prostatomembranous. Now coming to the symptoms. So here you can see what are the symptoms. You can notice that there is urinary retention, there is blood at meatus, and there is collection of blood in the pelvis. So what kind of hematoma? Pelvic hematoma. Okay. What is the difference between posterior urethral injury and anterior urethral injury? At the place of pelvic hematoma in anterior urethral injury, there is superficial perineal hematoma. There is superficial perineal hematoma. There will be urinary retention. There will be blood at meatus. So this is the clinical feature of posterior urethral injury. What's the gold standard treatment for urethral injury? We perform suprapubic cystostomy. And after performing suprapubic cystostomy, we go for delayed repair. And this repair is performed generally within 3 months. So after SPC, we go for delayed repair. And this repair is done usually within 3 months. Within 3 months. Clear? So this is how we manage the patients of posterior urethral injury. First, see the mechanism of anterior urethral injury. So either there is external blow or kick to anterior part of urethra, or there is straddle injury, also known as manhole injury. So external blow or kick, straddle injury, or manhole injury. If we see what is the most commonly injured part of urethra, so this is what? Bulbar urethra. In anterior urethral injury, most commonly injured part of urethra is bulbar urethra. Now see the clinical features. Here also what? There is urinary retention. Here also you will find the blood at meatus, and here also there is hematoma, but the location of hematoma is different. You can see here that there is involvement of shaft of penis, involvement of bilateral scrotum, and the perineum. So what kind of hematoma is seen here? Perineal hematoma. Perineal hematoma. Urinary retention, blood at meatus plus perineal hematoma. Sometimes this hematoma is involving the shaft of penis, bilateral scrotum, which looks like a butterfly. So what kind of hematoma? You can see here, you can find butterfly hematoma. Butterfly hematoma. Management is very similar to posterior urethral injury. In this case also we go for SPC, suprapubic cystostomy, followed by delayed repair if patient develops symptomatic stricture. After urethral injury, patients are going to develop stricture urethra. So question, what is the most common cause of stricture urethra? Most common cause, it's trauma. Investigations are frequently asked in stricture urethra. See this picture. This is the normal retrograde urethrogram, dye is injected from the tip of penis. So here you can see this is penile urethra, this part is bulbar urethra, this is membranous, and this is prostatic urethra. Now see the important questions asked in relation to stricture urethra. What is the investigation of choice for diagnosis of posterior urethral stricture? And we discussed it's the micturating cystourethrogram, also known as MCU. And what is the investigation of choice for diagnosis of anterior urethral stricture? It is RGU, that's known as retrograde urethrogram. For adequate evaluation of urethral stricture, doesn't matter whether it is posterior or anterior, both MCU plus RGU is done. So if the question is asked for adequate evaluation of urethral stricture, which of the following should be done? RGU, MCU, both? You will choose both. And if the question is asked investigation of choice for diagnosis of posterior urethral stricture, MCU, anterior urethral stricture, that's RGU. See the management of urethral strictures. For stricture, you can go for dilatation. If a patient is having short bulbar stricture, what kind of? Short bulbar stricture. In these patients, we can perform optical internal urethrotomy. At which position? You have to remember 12 o'clock position. At 12 o'clock position. In short bulbar stricture, optical internal urethrotomy at 12 o'clock position. The management of stricture depends on the length of stricture also. So if length of stricture is up to 2 centimeter, we can excise the stricture and go for end-to-end anastomosis. So in this case, excision plus end-to-end repair or anastomosis. Problem: whenever the length of stricture is more than 2 centimeter, in that case you can excise, but you cannot pull both ends together because it will lead to recurrence. So in these cases, after excision we have to go for reconstruction with tissue transfer. We perform the reconstruction. So from where we are going to take the tissues for reconstruction? Most commonly from buccal mucosa. Other areas are bladder mucosa and penile skin. So for this reconstruction, most commonly preferred donor site is buccal mucosa. So this is how we manage the patients of urethral stricture. This is a case of Peyronie's disease. What is the other name? It is also known as penile fibromatosis. Name is penile fibromatosis. What's the problem? See, over the dorsolateral aspect of penis, you can see there is presence of what? Fibrous plaque. What's that? Fibrous plaque. So generally in this case, there is chronic vasculitis involving tunica albuginea, and there is presence of fibrous plaque over the dorsolateral aspect of penis. That's why at the time of erection, what happens? You can see there is upward curvature. What? Upward curvature. There is painful erection. There is poor erection distal to this fibrous plaque. So these are the problems with Peyronie's disease. There is a triad associated with Peyronie's disease. What's the name? Galezia's triad. So in Peyronie's disease, there is Galezia's triad. What are the components of Galezia's triad? There is Dupuytren's contracture, there is Peyronie's disease, and retroperitoneal fibrosis. So how to remember? It is DPR. DPR in Galezia's triad. Dupuytren's contracture, Peyronie's disease, retroperitoneal fibrosis. What's the treatment of Peyronie's disease? What is the good thing? That in more than 50% cases, there is spontaneous resolution. So only observation and emotional support is required. If there is no spontaneous resolution in those patients, we go for surgery, and that is known as Nesbit operation. So Nesbit operation is performed for Peyronie's disease, and in TURP we discussed most preferred technique is Nesbit technique. Nesbit technique for TURP, Nesbit operation for Peyronie's disease. What is the most common histological type of carcinoma penis? You know, it is squamous cell carcinoma. We discussed squamous cell carcinoma is more common in low socioeconomic status. So carcinoma penis is also seen in low socioeconomic status. It is associated with virus infection. Which one? HPV infection. Which strain? 16, 18, 31, 33. Generally, it is seen in 5th to 6th decade, but 40% of patients are less than 40 years of age. What is the problem here? You notice that more than 50% patients have phimosis. So carcinoma penis patients have phimosis, and phimosis is the risk factor for carcinoma penis. So what is protective? Circumcision. What kind of circumcision? Neonatal circumcision is protective. Neonatal circumcision means performed within 1 month of birth. So neonatal circumcision is protective for carcinoma penis. This is a pre-malignant condition for carcinoma penis. Can you see? It is locally malignant. The name is Buschke-Lowenstein tumor. So what's the name of this condition? It is Buschke-Lowenstein tumor. Right? Buschke-Lowenstein tumor. This is also known as verrucous carcinoma. It is locally malignant, destroy the surrounding tissues by compression, not by invasion. It's a pre-malignant condition for carcinoma penis. There are two forms in relation to carcinoma in situ. Carcinoma in situ in relation to penis is known as Bowen's disease. It's the Bowen's disease. And there is a second situation in which the carcinoma in situ is involving only glans penis. Here you can see red velvety lesion involving glans penis. This is erythroplasia of Curette. You have to remember erythroplasia of cure it. Clear? So these are the carcinoma in situ forms. Now coming to the site. What's the most common site of carcinoma penis pneumonicus GPS? It is the glans, followed by prepuce, followed by sulcus. What's the most common presentation of carcinoma penis? So you are going to find the lesion. So patient will tell you that this is the lesion and it is associated with foul smelling discharge. Foul smelling. Important point, there is minimal or no pain in carcinoma penis. So the most common presentation is lesion with foul smelling discharge. Second important point, more than 50% patients at the time of presentation, they have inguinal lymphadenopathy. What's the problem? There is inguinal lymphadenopathy, and this inguinal lymphadenopathy can be because of sepsis and it can be because of metastasis. So it can be because of sepsis or metastasis. So any patient who is coming to us with inguinal lymphadenopathy and patient is having carcinoma penis, in all those cases we give antibiotics for how much duration? 4 to 6 weeks. Antibiotics are given for 4 to 6 weeks. Now the problem, inguinal lymph nodes are enlarged, and if intervention is not done, these enlarged lymph nodes are going to cause the erosion of femoral vessels, and because of this erosion there is bleeding. So what's the most common cause of death in patients of carcinoma penis? It's the bleeding caused by erosion of femoral vessels. Why? Because these patients have inguinal lymphadenopathy. Most common cause of death, bleeding caused by erosion of femoral vessels. Second most common cause of death. What's the second most common cause of death? And that is sepsis. What is the most common route of spread? It is hematogenous. What is the most common site of metastasis? It is lungs. Investigation of choice for diagnosis, since the malignancy is accessible, we take biopsy. So important questions. Most common route of spread. Okay, this is hematogenous. And what's the most common site of metastasis? It's the lungs. Investigation of choice for diagnosis, that's biopsy. And very important question, investigation of choice for staging, it's MRI. Investigation of choice for staging, it is MRI. We discussed in carcinoma penis also we can perform sentinel lymph node biopsy. Who performed sentinel lymph node biopsy for the first time in carcinoma penis? Cabana. And that's why sentinel lymph node biopsy in carcinoma penis is known as Cabana procedure. It's known as Cabana procedure. Now see the management of carcinoma penis. Imagine that the malignancy involved prepuce only. If there is involvement of prepuce only, in that case what we can go for? Circumcision. This was asked many times in NEET and DNB, that circumcision is sufficient for which type of carcinoma penis? Involving only prepuce. One. Second, if there is involvement of distal part of penis, so carcinoma penis involving this distal part, in that case what we go for? Partial penectomy. So in this situation we go for partial penectomy. Okay. And third situation, if the patient is having carcinoma involving the proximal part of penis, in this case we perform total penectomy and we perform the opening here, urethral opening here. This is perineal ureterostomy. So if it is involving proximal part, then we go for total penectomy and perineal ureterostomy. So it's total penectomy plus perineal ureterostomy. Okay, we have chemotherapy agents also which are used in carcinoma penis. One is bleomycin and second is cisplatin. So which two agents are used commonly? Bleomycin for carcinoma penis and cisplatin. So this is how we manage the patients of carcinoma penis, and this is all about penis and urethra. Now we are going to start testis and scrotum. First we are going to discuss undescended testes. What is the incidence of undescended testes at birth and at 1 year of age? If we see the incidence at birth, it is 3%. And how much is the incidence at 1 year of age? This is 1%. Both of these questions were asked. In how many patients there is spontaneous descent? So if we see by 3 months of age, spontaneous descent occurs in 70 to 77% of patients. That's why we have to wait. Why? Because by 3 months of age, spontaneous descent occurs in 70 to 77% of cases. What are the types of undescended testes? So it is of two types. One is inguinal and the second is intra-abdominal. Here you can see there is testis present in inguinal canal, and if you are going to palpate it, it is palpable. So inguinal undescended testis is also known as palpable undescended testis. And this is intra-abdominal undescended testis. This is non-palpable. So what's the other name? Intra-abdominal undescended testis is also known as non-palpable undescended testis. Why testis is placed in scrotum? You know, because the temperature is 2 degrees centigrade below the body and effective spermatogenesis should be going on. Problem: if testis is not descended in the scrotum, what's the problem? There are histopathological changes also in the testis. What's the earliest histopathological change in undescended testis? Earliest histopathological change, and it's the hypoplasia of Leydig cells. Means the number of Leydig cells are reduced. Earliest histopathological change is hypoplasia of Leydig cells. There are many complications also of undescended testis. How to remember the complications? The mnemonic is SATHI. What's the mnemonic? It's the SATHI. So S means sterility, A means atrophy, T means trauma, tumor, torsion. This question is most frequently asked, that what's the most common tumor seen in undescended testes? And the most common tumor seen in undescended testes is seminoma. Seminoma. Imagine we are going to compare whether the risk of testicular tumor is more in inguinal testes or in abdominal testes. So obviously in the abdominal testes, because higher the testes, greater the risk. Higher the testes, greater the risk. There is hernia. Why? Because in more than 90% cases, there is patent processus vaginalis and there is inflammation, right? In patients of undescended testes, we perform the orchidopexy. You have to remember that orchidopexy doesn't decrease the risk of testicular tumor. It only facilitates early detection of testicular tumor. Very important finding. So, orchidopexy. We perform orchidopexy. Orchidopexy doesn't decrease the risk. It only facilitates early diagnosis. You have to remember, facilitates early diagnosis or early detection of testicular tumor. See how we are going to make the diagnosis of undescended testes. There are two questions which are frequently asked, one in NEET and one in AIIMS. First question: investigation of choice for diagnosis of undescended testes. And the question which was asked in AIIMS, it was non-palpable undescended testes. So this was non-palpable undescended testes. Okay, so investigation of choice for diagnosis of undescended testes, that is inguinal exploration, because it's palpable. And if it's non-palpable, in that case we perform diagnostic laparoscopy. So here it is inguinal exploration. Okay, and if it is non-palpable, in that case we go for diagnostic laparoscopy. Diagnostic laparoscopy. This was the question in AIIMS. So here you can see this is the deep ring. Okay, we start tracing the structures from deep ring. First we are going to trace what? Vas deferens. So when we are tracing this vas deferens, and we are going to find that vas is blind. If vas is blind, testis may or may not be present. Then we trace testicular vessels, especially which one? Testicular artery. So we trace testicular artery. And if testicular artery is also blind, it means there is testicular agenesis. Agenesis. Okay. So trace the vas. If it's blind, testis may or may not be present. Trace testicular artery. If testicular artery is also blind, there is testicular agenesis. And this was the question. If testicular artery is blind, what will you do? We have to abandon the procedure. Okay. Otherwise, we are going to find the testis. And if you find the testis, you have to perform what? Orchidopexy, means bring it back to the scrotum. Question: what's the best age for performing orchidopexy? The best age for orchidopexy is 6 months. It should not be delayed beyond 12 months. So range is there. It's 6 to 12 months. In exam they ask best age, and the best age is 6 months. Which type of orchidopexy is having best result? It's the microvascular testicular autotransplantation. Microvascular testicular autotransplantation. This is having best results. What's the problem in ectopic testis? Here, the testis is normally developed. There is normal descent up to the inguinal canal. So up to the inguinal canal, there is normal descent. But what's the problem? In the groin, there is abnormal location. In the groin, there is abnormal location. What is the most common site of ectopic testis? It is superficial inguinal pouch. That's the most common site. And what is the least common site? It's the contralateral scrotum. Testis is normally developed. It is palpable. In this case also, we have to perform what? Orchidopexy. And what's the best age? Same answer here, 6 months. And in this case, the orchidopexy should not be delayed by 2 years. So best age for orchidopexy in ectopic testis, 6 months. It should not be delayed by 2 years. What happens in acute epididymoarthritis? It is characterized by ascending bacterial infection because of UTI or because of STD. So you can see the organism via urethra is going where? To the epididymis. So there is inflammation of epididymis and then testis. So what happens? There is inflammation of epididymis, epididymitis, inflammation of testis, arthritis. So this is epididymoarthritis. If the patient is sexually active male, age less than 35 years, what's the most common organism? It's chlamydia. Sexually transmitted disease, what? It's chlamydia. And in children, in elderly, and in homosexuals, what's the most common organism? It's E. coli. So when these patients are coming, they are having the signs and symptoms suggestive of what? UTI or infection. It means there is burning micturition, there is low grade fever, there is pain in inguinoscrotal region. Whenever these patients are coming to us, we perform some examination. On examination, if you are going to elevate the testis, what? Pain is relieved. It means Prehen sign is positive. Cremasteric reflex is present. And if we palpate, the cord is thickened. So what are the examination findings in such patients? Important examination findings. There is Prehen sign. This Prehen sign is positive. Cremasteric reflex. Cremasteric reflex, it's present. Clear? And there is thickened cord. What? There is thickened cord. These are the examination findings. How we are going to make the diagnosis? Ultrasound. On ultrasound, you are going to find that the cord is thickened. There is additional finding which you are going to find. What? That this patient is having secondary hydrocele. So on ultrasound, there is thickened cord and secondary hydrocele. And you know, most common cause of secondary hydrocele worldwide is acute epididymoarthritis. There is inflammation, there is infection. So what's the treatment? We give analgesics, NSAIDs, we give antibiotics and rest. So this is how we manage epididymoarthritis. What happens in testicular torsion? So if torsion occurs outside tunica vaginalis, it is extravaginal, and if it occurs inside tunica vaginalis, this is intravaginal. Okay, which one is more common? It's the intravaginal testicular torsion, which is most common. What happens here? You can see this is the tunica vaginalis. You can see this is the tunica vaginalis. It's normal. In some patients, there is high investment of tunica vaginalis, and this high investment of tunica vaginalis, it's known as bell clapper's deformity. So what happens? So testis is hanging like a clapper in the bell, and what happens? There is torsion within the tunica vaginalis. So this is intravaginal testicular torsion. Generally, it is seen in young patients aged 10 to 25 years of age. What's the problem? Because of torsion, there is ischemia, and because of this ischemia, this patient is having severe agonizing pain. There is severe agonizing pain. It is so severe that it is also associated with nausea and vomiting. When these patients are coming to us, we are going to perform the examination. If you are going to look at the testis, affected testis is riding in the upper part of scrotum. So high riding testis, and that's known as Deming sign. Affected testis is high riding in the scrotum, that's Deming sign. If you see the contralateral testis, that's normally lying placed transversely, and that's known as angel sign. Angel sign. So you have heard the story of Vikram Vetal. The Vetal is hanging from the tree, high riding. So this is demon or Deming, and Vikram is on the ground. So normally lying, contralateral testis is normally lying placed transversely, angel sign. Important signs. You are going to elevate the testis. Pain is not relieved because pain is because of ischemia. So here, Prehen sign is negative. Prehen sign, it's negative. Cremasteric reflex, this is absent. You know, testicular torsion is an emergency. We have to make the diagnosis. And what's the investigation of choice for diagnosis? It's the Doppler. After confirmation, the surgery should be done within 4 hours. In testicular torsion, orchidopexy should be done within 4 hours. So in treatment, what we are going to perform? We perform orchidopexy. Yes, it should be done within 4 hours. You have to remember the limit. Whenever we are performing orchidopexy, after performing orchidopexy, we have to check the contralateral scrotum to look for any deformity. If there is bell clapper's deformity in the contralateral scrotum, we have to perform bilateral orchidopexy. Bilateral orchidopexy. Clear? So you know that bell clapper's deformity increases the risk of testicular torsion. Inversion of testis increases the risk of testicular torsion. Whenever there is bell clapper's deformity, we perform bilateral orchidopexy. What are the types of hydrocele? See this first one. Here what you can notice that this is patent processus vaginalis, and patent processus vaginalis is seen in congenital hydrocele. What is the good thing? That spontaneous obliteration occurs by 2 years of age, and if there is no obliteration by 2 years of age, what's the treatment of choice of congenital hydrocele? Herniatomy. Herniatomy. So it is characterized by patent processus vaginalis. Spontaneous obliteration occurs by 2 years of age. If no obliteration by 2 years of age, we perform herniatomy. See the second picture. You can see this is the superficial ring and this is the deep ring. Here you can see the processus vaginalis is patent up to the top of testis, and this is known as funicular hydrocele. So in funicular hydrocele, processus vaginalis is patent up to the top of testes. Okay, see the third picture. Here you can see this is the processus vaginalis and it is patent up to the deep ring. So processus vaginalis is patent up to the deep ring, and this is known as infantile hydrocele. In infantile hydrocele, processus vaginalis is patent up to the deep ring, but there is no communication with peritoneal cavity. In the fourth image, you can see that there is obliteration of upper part as well as lower part of processus vaginalis. This is known as hydrocele of cord, also known as encysted hydrocele. What? Hydrocele of cord, also known as encysted hydrocele. If we pull testes, this swelling goes down. You release testes, this swelling moves up. In the fifth image, you can see that there is obliteration of processus vaginalis with collection of fluid. So within tunica vaginalis, there is collection of fluid, and this is known as vaginal hydrocele. Overall, the most common type of hydrocele is the vaginal hydrocele. If you see the number 6 here, you can notice that there are two sacs, and these two sacs are communicating with each other near neck of scrotum. So two sacs communicating with each other near neck of scrotum, that's why it is also known as bilocular hydrocele. It is also known as hydrocele in bisac. How many sacs? Two. So it is also known as hydrocele in bisac. If you see this seventh image, this was the question asked in AIIMS. You can see testes, cord structures appear normal. This is the hernia sac. And what you notice here in this hernia sac, that the neck of sac is obliterated or it is plugged. So when the neck is closed by adhesions or it is plugged by omentum, and in this hernia sac there is collection of fluid, this is hydrocele of hernia sac. So what happened? In the hernia sac there is collection of fluid. These are the types of hydrocele. Most common type, vaginal, we are going to discuss. So here you can see there is collection of fluid within tunica vaginalis. This is vaginal hydrocele. Vaginal hydrocele is of two types. One is primary vaginal hydrocele and one is secondary. Secondary is secondary to some etiology like trauma, tumor, acute epididymoarchitis. What is the most common cause of secondary vaginal hydrocele? We discussed acute epididymoarchitis. Secondary hydrocele is smaller, that's why it is lax. You can palpate testes separately. If we see the primary vaginal hydrocele, which is the most common type overall, here it is tense. So testes cannot be felt separately. We can get above the swelling, means we can get above the testes, but testes cannot be felt separately. And if we perform the trans-illumination test, it is positive. So see this patient who is having primary vaginal hydrocele. Here it is tense, testes cannot be felt separately, and on trans-illumination test, see the finding, it is positive. So trans-illumination is positive. Okay. How we are going to manage the patients of hydrocele? If it's small hydrocele, we go for Lord's plication of sac. What? Lord's plication of sac. If it's medium sized hydrocele, in this case we go for Jaboulet's eversion of sac. Jaboulet's eversion of sac. And if it's large hydrocele, in such cases we go for excision of sac. So this is how we manage patients of hydrocele. See what happens in varicocele. So you can see that there is dilated, tortuous, pampiniform plexus of veins located posterior and above testis. What's the location? Posterior and above testis. Dilated, tortuous, pampiniform plexus of veins located posterior and above testis. You know that it is more common on left side. Why it is more common on left side? Because this left gonadal vein drains at right angle to the left renal vein. Left gonadal vein drains at right angle to left renal vein. So there is increased transmission of pressure. One. Second, there is nutcrackers phenomena. What's that nutcrackers phenomena? This is aorta. This is superior mesenteric artery. So imagine I'm the aorta. This is the superior mesenteric artery. This is the left renal vein. So this is compressed between these two vessels, and this is known as what? nutcrackers phenomena. So these are some of the causes why it is more common on left side. More common on left side. You know, varicocele leads to reversible atrophy in adolescent males. What is the presentation of varicocele? These patients come to us with swelling and discomfort in the scrotal region. This swelling becomes more prominent on standing position and it decompresses on the lying down position. In advanced stages, what there is bag of worm like sensation. Bag of worm like sensation on palpation. So here you can see varicocele. It is more common on left side. You can see here this is left testicular vein. There is another condition known as suspicious varicocele. What's that suspicious varicocele? You know that in patients of renal cell carcinoma there is vascular invasion. So if there is vascular invasion because of RCC, renal cell carcinoma, in such patients also there is varicocele. Why? Because this renal vein is blocked. But this varicocele is having short history. It is common in elderly and it doesn't decompress on lying down position. So in RCC, we find varicocele, which is known as suspicious varicocele. Characteristic features, short history, seen in elderly, and it doesn't decompress on lying down position. You know, the temperature around the testis is increased. Why? Because of network of veins around the testis. That's why the spermatogenesis is affected. So on semen analysis, what are the two parameters which are most severely affected? One is motility, and the second is number, means sperm count. So sperm motility and sperm count is most severely affected on semen analysis, most commonly affected on semen analysis. How we are going to make the diagnosis? So investigation of choice for diagnosis, obviously it's Doppler, because there is network of vein, increased vascularity around testis. And what's the gold standard investigation? Problem is related to vein. So the gold standard investigation, it's the venography. The management is very easy to remember. We are going to ligate pampiniform plexus of veins near deep ring. This is known as high inguinal ligation. This is high inguinal ligation of pampiniform plexus of veins. 1. Second, you can ligate the left gonadal vein or left testicular vein in the retroperitoneum. So this is retroperitoneal ligation of left gonadal vein or left testicular vein, and this is known as Palomo's operation. What's the name? This is known as Palomo's operation. Which surgery is having best results? So if we are going to perform microvascular subinguinal ligation of pampiniform plexus of veins, it's microvascular subinguinal ligation, and this one is having best results. Simple. If we ligate pampiniform plexus of veins, what's the venous drainage? How the venous drainage of testis will occur? So there is a vein known as cremasteric vein. So the alternative venous drainage occurs via cremasteric veins after ligation of pampiniform plexus of veins. This is spermatocele, and in this spermatocele there is collected fluid which contains spermatozoa, and it is having what kind of appearance? It's having barley water appearance. The fluid is having barley water appearance. There is another question. Chinese lantern pattern is seen in epididymal cyst. So another question. There is Chinese lantern pattern, and this Chinese lantern pattern, it is seen in epididymal cyst. These are two one-liners questions which are frequently asked. Barley water appearance of fluid in spermatocele, Chinese lantern pattern in epididymal cyst. This is the spot diagnosis. This is Fournier's gangrene. It is also known as idiopathic scrotal gangrene, and you know it's a polymicrobial infection which is caused by both aerobes as well as anaerobes. Polymicrobial infection. It is a type of necrotizing fasciitis. It means the structures are involved till fascia. Necrotizing fasciitis. So there is necrosis of the structure till fascia. It means there is necrosis of skin, necrosis of superficial fascia, necrosis of deep fascia. So what are the structures involved? Skin, superficial fascia, deep fascia. What are the structures spared in Fournier's gangrene? So if you see this image, you can make out that what are the structures which are spared. The necrosed structures are removed, skin, superficial fascia, deep fascia. But you can see testes, cord structure, corpora cavernosa, corpora spongiosa, and urethra. These are spared. So testes, cord structure, corpora cavernosa, spongiosa, urethra, these are spared in Fournier's gangrene. Whenever these patients are coming to us, they complain of what? Severe pain. There is blackish or purplish discoloration in the perineum. There is fever, marked systemic toxicity. There is a characteristic odor, and what's that odor? There is fetid odor. What kind of discharge these patients are having? Dishwater discharge. So important points: severe pain, marked systemic toxicity, purplish or blackish discoloration, fetid odor, dishwater discharge. So here you can see how we are going to treat. We have to excise the involved necrosed skin, superficial and deep fascia. So in the management, we go for extensive surgical debridement. We go for extensive surgical debridement apart from providing IV fluids and IV antibiotics. And when patient general condition improves, we are going to cover the testes with the help of skin grafting. See the one-liner questions related to testicular tumor. First question: what's the most common testicular tumor? And you know it is seminoma. If mixed is given in the option, go for mixed. Why? Because 95% component, 90 to 95% component is seminoma, 2 to 3% component is teratoma, yolk sac tumor, embryonal carcinoma. So actually speaking, it is mixed, but major component is of seminoma. So it is seminoma or mixed. What is the most common primary bilateral testicular tumor, and what is the most radiosensitive testicular tumor? It is seminoma. What? Seminoma. What's the most common testicular tumor in children and the testicular tumor having best prognosis? It is yolk sac tumor. This is yolk sac tumor. You have to remember the age. Most common testicular tumor in children, age 1 to 3 years. If there is twist in the question that what's the most common testicular tumor in prepubertal children, the age is 11 to 13 years, and in these patients the answer is teratoma. It's teratoma. What is the most common testicular tumor in elderly? Overall, what is the most common bilateral testicular tumor? We discussed most common primary bilateral testicular tumor, that is seminoma. But overall most common bilateral testicular tumor and the most common secondary testicular tumor, answer is same for all these three, that's lymphoma. So most common testicular tumor in elderly, most common bilateral testicular tumor, and most common secondary testicular tumor is lymphoma. What kind of lymphoma? So obviously in the testes there is non-Hodgkin's lymphoma. This is extragonadal lymphoma. And in non-Hodgkin's lymphoma, which type is most common? It's DLBL, diffuse large B-cell lymphoma. Not only in testes, there are many sites in the body where DLBL is the most common type of lymphoma. So it's very easy to remember. DLBL is the most common type of lymphoma where primary CNS lymphoma, orbital lymphoma, thyroid lymphoma, breast lymphoma, gastric lymphoma, small intestinal lymphoma, appendicular lymphoma, colonic lymphoma, rectal lymphoma, and testicular lymphoma. In gastric lymphoma, in Robbins it's written that most common type of lymphoma is myeloma. That's wrong. It's DLBL which is more common than myeloma. So how to remember? You have to remember it from top to bottom. Primary CNS lymphoma, orbital lymphoma, thyroid, breast, gastric lymphoma, small intestinal, appendicular, colonic, rectal and testicular. So at all these places the most common type of lymphoma is DLBL. There is a type of testicular tumor which is having early hematogenous spread. Generally in testicular tumor, what is the most common route of spread? It's lymphatic. But there is testicular tumor which is having early hematogenous spread. If there is early hematogenous spread, there will be early pulmonary metastasis, and if there is early metastasis, it's having worse prognosis. What's the name of that testicular tumor? It's choriocarcinoma. What's that? It's the choriocarcinoma. We discussed what is the most common type of testicular tumor, seminoma. In which particular age group seminoma is seen, 3rd to 4th decade. These patients are coming to us telling that there is painless mass in relation to testes. What's the presentation? There is painless mass in relation to testes. Apart from this, you will notice that 10% patients have secondary hydrocele. Secondary hydrocele, we discussed what is the most common cause of secondary hydrocele, acute epididymoarchitis, but it can occur in testicular tumor also. 5% patients have gynecomastia at the time of presentation. At the time of presentation, there is gynecomastia. What is the most common route of spread we discussed? Yes, lymphatic. So which group of lymph nodes are involved? It's the retroperitoneal lymph nodes, most commonly para-aortic lymph nodes. We perform the examination. When you perform the examination, you will notice that affected testis is enlarged, it's hard, and there is mass in relation to testis. Okay. Question is asked, what's the first investigation done in a suspected case of testicular tumor? The first investigation is what? Ultrasound. So we perform ultrasound. And what are the findings on ultrasound? You can see that there is enlarged and hard testes. You are going to notice that there is hypoechoic mass in relation to testes. And what else? Secondary hydrocele. FNAC and biopsy are contraindicated. This question was asked many times. What? FNAC and biopsy, these are contraindicated. Why? Because scrotum is having separate lymphovascular supply, testis is having separate lymphovascular supply. If you perform FNAC or biopsy, there is seeding of needle tract and involvement of inguinal lymph nodes. So FNAC, biopsy, these are contraindicated. On the basis of suspicion only, when there is strong suspicion, we perform what? High inguinal orchidectomy. On the basis of suspicion, okay, we perform high inguinal orchidectomy and we send the specimen to pathology department. Which other investigation is done? We had to perform CCT. Why CCT abdomen is performed? We want to look for retroperitoneal lymphadenopathy. We discussed most commonly involved group of lymph nodes, it's para-aortic. Okay, so for retroperitoneal lymphadenopathy, CCT is done. What are the important tumor markers in relation to testes? First is alpha fetoprotein. How to remember? Alpha fetoprotein is raised in yet. Y, yolk sac tumor, E, embryonal carcinoma, and T, teratoma. Second is beta HCG. How to remember? Beta HCG is raised in CIS. C means choriocarcinoma, E means embryonal carcinoma, S means seminoma. Production of beta HCG is the primary property of choriocarcinoma because there is presence of syncytial trophoblast. Only 10% patients of seminoma are having raised beta HCG because there is syncytial trophoblast, only 10%. Apart from these, there are other markers which are based on bulk of disease like LDH, lactate dehydrogenase, placental alkaline phosphatase, PLAP, and gamma glutamyl transpeptidase, GGT. So these are the three markers which are based on bulk of disease. Bulk. You know, for most of the tumors we have TNM staging. But for testicular tumor, there is TNM-S staging. And in this S, serum markers are included. Which markers are included? Alpha fetoprotein, beta HCG, and LDH. So this S includes alpha fetoprotein, beta HCG, and LDH. In testicular tumors, what is the good thing? That high inguinal orchidectomy is already done. Tumor is removed already. So on the basis of histopathological diagnosis, which type is there and what's the stage, we have to plan the treatment. It's very easy to understand. Most radiosensitive testicular tumor is seminoma. Tumor is removed. If there is retroperitoneal lymphadenopathy, we go for radiotherapy. And if it's non-seminomatous germ cell tumor, in that case, we have to go for retroperitoneal lymph node dissection. So see how we are going to manage the patients. If the stage is 1A, 1B, 2A, 2B, in these stages, in seminoma, radiotherapy. And in non-seminomatous germ cell tumor, we go for RPLND, that's retroperitoneal lymph node dissection. If advanced stage is there, that's 2C, 3 and 1S. What is 1S? In which serum markers are raised. In these cases, in both seminoma as well as in non-seminomatous germ cell tumor, chemotherapy is given. Even after chemotherapy, if there is some residual mass, we perform retroperitoneal lymph node dissection. Okay, so what's the chemotherapy regimen? It is BEP. Components are bleomycin, etoposide, B means platin. So it is cisplatin. How many cycles of BEP we give? 6 cycles. 6 cycles of chemotherapy is given in patients of testicular tumor. Let's quickly revise the stones of urology. So what is the most common renal stone? It's calcium oxalate. What is the most common radiolucent renal stone? It is uric acid. What is the most common primary bladder stone? We discussed ammonium urate. Ammonium urate. What is the most common type of secondary bladder stone? And it is uric acid followed by struvite. Calcified corpora myelitia, that is prostatic stone. And what's the composition? It's calcium phosphate. So these are the stones related to urology. Let's have a look of other important stones also. What's the most common gallstone? We discussed cholesterol, in bracket mixed if given in the option. And what's the most common type of pancreatic stone or salivary gland stone? Answer is same. That's calcium carbonate. Is the calcium carbonate. So these are important points related to stone, and this is all about urology. Now we are going to discuss arterial disorders. First, we are going to discuss the characteristic features of peripheral arterial occlusion. You know, peripheral arterial occlusion, it is characterized by 5 P's. So what are those 5 P's? It's pain, pallor, paresthesia, pulselessness, paralysis. Out of these 5, which one is most common? Pain is the most common symptom of peripheral arterial occlusion. And there is a latest question which was asked in INI-CET, that which of the following is having worse prognosis in peripheral arterial occlusion? So it's the paralysis. Paralysis is associated with worse prognosis, and the most common symptom, it's the pain. The patients who are having arterial occlusion, in these patients there is intermittent claudication because of muscle ischemia, and this intermittent claudication is seen distal to obstruction. Okay, imagine this is the buttock region, this is the thigh region, and this is the calf region. Imagine a patient who is having aortoiliac disease. So for situation, if a patient is having aortoiliac disease, so you can make out in such patients where is the claudication. So in such patients you will notice claudication in buttock, in thigh, and in calf region. These patients are also associated with Leriche syndrome. Lerich syndrome is seen in patients having aortoiliac disease or occlusion. And you know, Lerich syndrome is characterized by erectile dysfunction leading to impotence. So, important points, there is erectile dysfunction and impotence in Lerich syndrome. If there is occlusion of this common femoral artery, in this case, where is the claudication? You will notice the claudication in thigh and in the calf region. Imagine the patient who is having occlusion in superficial femoral, occlusion in popliteal or crural arteries or crural arteries. Okay. So, in superficial femoral, popliteal or crural artery disease, in these cases, where is the claudication? Only in the calf region. So, you noticed intermittent claudication is seen distal to the obstruction, and it's because of ischemia of muscles. What is the most common cause of peripheral arterial occlusion? So, it is the atherosclerosis. And in young male smokers aged less than 40 years, what's the cause? It's the Burgess disease. Burgess disease is also known as thromboangiitis obliterans. Thromboangiitis obliterans. And in this case, you are going to notice that medium and small sized vessels are involved. So, what are those small and medium sized vessels which are involved? Mnemonic is TPR. It's tibial, plantar, radial. It means both lower limb as well as upper limb vessels are involved. It's more common in lower limb. Second thing, there are presence of skip lesions. And third thing, the disease progress from distal to proximal direction. Distal to proximal direction. So there is involvement of small and medium sized vessels. There is presence of skip lesions and it progress from distal to proximal direction. Initially there is involvement of artery. Initially there is involvement of artery, but this inflammatory process is going to involve vein and nerve. So ultimately you are going to notice that all three structures are involved in thromboangiitis obliterans or Burgess disease. And we discussed that this is seen in young male smokers age less than 40 years. What are the clinical features? So it is characterized by a triad, and how to remember, the mnemonic is RIM. R, Raynaud's phenomena. I, intermittent claudication. And M, there is migratory superficial thrombophlebitis. Raynaud's phenomena, intermittent claudication, migratory superficial thrombophlebitis. Related to this intermittent claudication, there is a question that what's the grading of intermittent claudication, and it's known as Boyd's classification. According to Boyd's classification, what is grade 1? So when patient is going to start the walk, there is pain, but pain disappears if patient continues to walk. Why? Because the substance P which is collected is washed away. What is grade 2? There is pain, but patient can walk with pain. In grade 3, what is grade 3? Pain compels the patient to take rest. So patient walk for a certain distance, take rest and then walk. And in grade 4, the patient is going to develop rest pain. Burgess disease is an arterial disorder, mainly arterial disorders. What is the investigation of choice? Angiography. Both lower limb as well as upper limb are involved. That's why we go for forelimb angiography. So investigation of choice for diagnosis of Burgess disease, it is forelimb angiography. And we discussed that on angiography you are going to find characteristic collaterals. So what's the name of this collateral? This is known as corkscrew collaterals. So these are known as corkscrew collaterals. Okay, corkscrew collaterals in Burgess disease. What is ankle brachial pressure index, also known as ABPI in short, or ABI? So it's the ratio of systolic blood pressure at ankle and in the arm, right? This is ABPI or ABI. Very important in patients of Burgess disease. What's the normal value? The normal value is 1 to 1.2. Imagine if the ankle brachial pressure index is 0.1 to 0.4, it is suggestive of critical limb ischemia. If it's 0.5 to 0.9, it is suggestive of intermittent claudication. And in a latest exam in NEET PG, and in a latest exam, this value was asked that ankle brachial pressure index is more than 1.2. What does it mean? It means that the vessel is calcified. And in which cases you are going to find the calcified vessels? Patients having diabetes mellitus and end stage renal disease. What are the treatment options available for Burgess disease? First thing, that patient should stop smoking. So abstinence from smoking. For symptomatic relief, sometimes we give vasodilators. What are the agents we give? One is xanthinol nicotinate. And what's the brand name of this xanthinol nicotinate? The brand name is Complamina. And the second agent we give, that is pentoxifylline. What's the brand name of pentoxifylline? It's Trental. We perform lumbar sympathectomy also. In which particular patient we perform lumbar sympathectomy? It is performed for the patients who are having rest pain. We can go for omental transposition. It's not having good results. Amputation. So in one exam, this question was asked that a patient of Burgess disease is having this particular problem. Patient is having gangrene of the toe, and in such cases we have to go for amputation. So if patient is having gangrene, in those cases we go for amputation. Out of this list, the most important is this lumbar sympathectomy. This lumbar sympathectomy is frequently asked. You have to remember one important finding, that intermittent claudication is not an indication for lumbar sympathectomy. It's the rest pain. What we remove in lumbar sympathectomy, we are going to remove from L1 to L4 ganglia if it is performed on one side. If we are performing bilateral lumbar sympathectomy, then to prevent retrograde ejaculation, at least L1 should be preserved on one side. If bilateral lumbar sympathectomy is being done, at least L1 should be preserved from one side to prevent the complication of retrograde ejaculation. Whenever we are performing lumbar sympathectomy, sometimes we are going to remove some other structures. So in lumbar sympathectomy, what are the structures accidentally removed? And how to remember? This is very, very important. It was asked in AIIMS also, NEET also. GPL, genitofemoral nerve. P means psoas sheath, psoas minor, and L means lymphatics. So there is accidental removal of genitofemoral nerve, psoas sheath, psoas minor, and lymphatics. What are the indications of lumbar sympathectomy? Indications are Burgess disease. In Burgess disease, rest pain, not the intermittent claudication. Atherosclerosis, Raynaud's disease, acrocyanosis, causalgia, hyperhidrosis, erythrocyanosis, frostbite. All these are indications. How to remember? The mnemonic is Bara-Sheff. What's the mnemonic? It's the Bara-Sheff. Burgess disease, atherosclerosis, Raynaud's, acrocyanosis, causalgia, hyperhidrosis, erythrocyanosis, and frostbite. Arteriovenous fistula can be congenital or acquired. Overall, which one is most common? This is a very common mistake you do in exam. Overall, it is congenital. Most commonly, it is congenital. What is the most common cause of acquired AV fistula? And the most common cause of acquired AV fistula is penetrating trauma. Is the penetrating trauma followed by iatrogenic. Okay, see, we create fistula for hemodialysis, but only the patients who are having renal failure are the patients who require hemodialysis. So what's the most common overall cause of AV fistula? It's congenital, and even in acquired, iatrogenic is not most common. It's the penetrating trauma which is most common. Iatrogenic fistula we create for hemodialysis, and what's the name of that fistula? It's Brachia fistula. You have to remember the name, Brachia fistula. And this Brachia fistula is created between radial artery and cephalic vein. So it is between which vessels? It is created between radial artery and cephalic vein. So here you can see this is the site of AV fistula. In AV fistula, what happens? Under pressure, the blood from artery starts going into vein. Because of that, what is the problem? There is increased venous return to the heart. And if there is increased venous return, there is increased cardiac output. If there is increased cardiac output, there is increased heart rate and there is increased systolic blood pressure. Simple. Increased venous return to the heart, so it is going to increase cardiac output, increases heart rate, increase in systolic blood pressure. But diastolic is not going to rise that much. It means there is wide pulse pressure. What's the problem? There is wide pulse pressure. So there is increased BP, there is tachycardia, there is wide pulse pressure. If you place your hand just over the site of fistula, you can feel the thrill. So what else? There is palpable thrill. You can see pulsatile mass. Palpable thrill is there.